pronounce it correctly, please forgive me. So I believe we have Dr. Mololo Noha, representing Director, Department of Disasters Management, Prime Minister's Office, Police, Parliament, and Coordination. Dr. Paul Chaote, Assistant Director, Earth Services, Pro-Large. Mr. Peter Mabwe, representing Assistant Director, Earth Promotion Section, Ministry of Earth. Lilian Masui, representing Commission of Social Welfare, the Ministry of Community Development, Gender, Women, and Special Groups. Professor Augusto Frumens, Dean School of Public Health and Social Sciences from Muhimbili University of Health and Health Sciences. Academic staff who are here, researchers, but also we have country representative, UNICEF, WHO, USAID, CDC, IOM, UNFPA, and other United Nations agencies. Let me also recognize keynote speakers for this symposium. Speakers, panelists, we have representatives from non-government organizations in the private sector. Dear participants, ladies and gentlemen, good morning. Good morning. So let me extend my warm welcome to you all to this very important symposium. And it is an honor to stand before you today as we embark on a journey for knowledge exchange and collaboration in advancing social and behavior change in emergencies. And I believe this symposium serves as a platform for interdisciplinary dialogue where experts from various fields converge to share insight, discoveries, and innovations. And I have looked at the timetable of this program, and I noted we have people from different disciplines, experiences, so I believe this will be a very successful symposium as you meet to share experiences. I have noted the theme of this symposium, and I believe it has been carefully selected to reflect the current global needs. It encapsulates the essence of a collective pursuit. And the theme is advancing social and behavior change in emergencies through high-impact approaches, forging synergies and partnerships to deliver advanced social and behavioral change in emergencies, connecting for impact change. I think there are quite a number of keywords in this theme, and I believe it will address the current global need. And I believe we have learned a lot with the COVID pandemic when we talk of the emergencies. So behavioral and social behavioral change, it is key in this kind of pandemics. Ladies and gentlemen, let me talk a bit about Muhimbili University of Health and Sciences. Probably most of you know what it is, but some you may not. Let me say that Muhimbili University of Health and Sciences, through the School of Public Health and Social Sciences, it is proud to partner with UNICEF country office to organize such a scientific event that has attracted participants across the globe. We have a long partnership between Muhimbili University and UNICEF. We have collaborated in a number of projects, including capacity building that address different areas in health and the allied sciences. So we thank UNICEF for remaining our strong partner in addressing the key issues in Tanzania. So I wish to thank the government of the United Republic of Tanzania, especially the President's Office, Regional Administration, and local government, as well as the Ministry of Health and the Ministry of Community Development, Gender, Women, and Special Groups for being part of this event. And as policymakers, the ministries are very important partners in this kind of symposium. And I believe that during the discussion and that the recommendations that we will make, this will be taken by the ministry for possible implementation. My heartfelt acknowledgement also to UNICEF country representative for both technical and financial support of this symposium. Ladies and gentlemen, I also extend my heartfelt gratitude to our esteemed guests who have graced us with their presence. There is a number of people that are present here, and we acknowledge your presence and participation in this conference. I also wish to thank other development partners, NGOs, private sector, and individuals who in one way or another have made this event a success, and thank you very much for coming this morning. Ladies and gentlemen, allow me now to just give a synopsis of Muhimbili University of Earth and Life Sciences. Historically, Muhimbili University of Earth and Sciences started way back in 1963. And for some members who are here who have gone through Muhimbili, we know this bit of history. It started with 10 students with one program. And this school then transformed into the Faculty of Medicine of the University of Dar es Salaam in 1991, where it was upgraded now to become a college of the Muhimbili University College of Earth Sciences, abbreviated as MOOCs. In 1996, the Faculty of Medicine that was upgraded to a constituent college of the University of Dar es Salaam, it was the aim to nurture it into a full-fledged university. Later on was merged with the Muhimbili Hospital to create the Muhimbili Medical Center. So we had the Muhimbili Medical Center that had the component of the hospital as well as the college. But subsequently in 2007, the MOOCs, the college was upgraded to a full-fledged university, now known as Muhimbili University of Health and Life Sciences. Tomorrow, which is 16th November 2023, we are marking 60 years of anniversary of Muhimbili University of Health and Sciences. We have organized a symposium tomorrow where we will look back where we came from 60 years. Some of us were not yet born. So to reflect of the achievements that have been made, the challenges that we have gone through, but to reflect it to the future where we want this very important institution in Tanzania to go. So as you know, the objectives of any university is advancements of knowledge, diffusion and extension of technology and learning. And we believe Muhimbili has achieved a lot in these areas. So for tomorrow, we will invite you all to come to Muhimbili campus. It's close to the Muhimbili National Hospital. We start at 9. So karibuni sana. MUAS, this Muhimbili University, has made a significant contribution in the training of human resource for health in Tanzania, including public health experts who serve in various ministries, departments, and agencies. And among other aspects of training at MUAS is behavioral change communication. We have a specific Master of Science program for behavioral change communication at the postgraduate level. And through this, MUAS has a wealth of experience in conducting research and community service activities within Tanzania and beyond. And we collaborate with a number of partner universities, government, and research institutions. So the context of social and behavioral change in emergencies at Muhimbili University has a long history. Let me say, the School of Public Health and Social Sciences, which is one of the 7 schools of this university, has been leading in teaching, research, and consultants in the aspect of social and behavioral change. And some of the staff from the school are actively participating in the implementation of social behavioral change in emergencies, spanning from these such as COVID-19 pandemic, cholera, and the recent outbreak that happened in Tanzania, the Marburg. So through this, a lot of evidence have been collected, and we believe some of the measures that are being implemented is because of the research that have been conducted by these people. And as you may know, the way the Marburg outbreak that happened in the Kagera region recently, it was very much controlled. It was very much controlled. And incidentally, actually, it happened in my own village. And luckily, it was easily controlled. We have few mortalities. And up to now, there are no new cases reported. And I think some of the interventions that were implemented is because of the research findings that have been conducted by people in this area. And as we know, outbreak like Marburg or cholera, I think behavior plays a major part. Behavior plays a major part. So we thank the researchers and the research groups that have been able to conduct research and provide evidence that have been used by the ministry responsible for health. In recent months, the School of Public Health and Social Sciences, with support from UNICEF, conducted a comprehensive social anthropological survey to identify social, cultural, and economic factors that may accelerate or hinder transmission of Ebola virus disease, EVD, in 5 risk regions of Tanzania and Zanzibar. The study was a breakthrough towards this symposium, and it provides a basis for further evidence generation and dissemination. And it is anticipated that up to 4 scientific papers will be generated from this study and published in peer-reviewed international journals. So once again, many thanks to UNICEF for this support and your cooperation. Ladies and gentlemen, this symposium unfolds across 3 days, with each day thoughtfully customized to dive into unique facets of the intricate landscape of the behavioral change and the public health emergencies. From what I have seen in the program, I noted the program will be moderated and managed by experienced moderators, keynote speakers, moderated panel discussions, and the presentation which will adeptly steer discussion that will foster robust engagement and interactive participation. And I believe this is the beginning of long-term collaboration in organizing such events. And our vision is growing further and organizing ERS Summit on social and behavioral change and emergencies. And I think in the course of our discussion, think about it, where you could be able to organize ERS Summit on the social and behavioral changes in emergencies. In addition, Muhimbili University of Health and Life Sciences is positioned to facilitate endless opportunities for experts to disseminate their findings to wider audience through both physical and online platforms. So MUAS is ready to support this kind of initiative. To make it clearer, I'm informed that the School of Public Health and Social Sciences and UNICEF are about to establish a Knowledge Management Center, which aims to create a dynamic knowledge sharing ecosystem by connecting knowledge nodes and fostering a culture of continuous learning and collaboration. And I commend this initiative as I believe it will help address knowledge dissemination challenge in Tanzania public health and social sciences domain and beyond. Ladies and gentlemen, and I believe this symposium is timely, as I mentioned, because of the emergencies that we are experiencing. So behavioral change is very important, and I believe through the presentation, the keynote address, and the discussion, you will be able to come up with the key recommendations. And we have the people from the responsible ministries, and I believe these recommendations will be taken that will address the key problem for implementation. There are recommendations that will address capacity building. As we have said, we need to build capacity in terms of training, but also we need to create programs. We need to conduct research to generate evidence that will further improve this discipline. Ladies and gentlemen, having said that, let me now declare the symposium titled Advancing Social and Behavioral Change in Emergencies Through High-Impact Approaches, Forging Synergies and Partnership to Deliver Social and Behavioral Change in Emergencies, Connected for Impact, is now officially open. Thank you very much.
I am sure you will all agree with me that VC deserves a bigger round of applause. So let's give him a bigger round of applause. Thank you very much for setting up the tone and officially opening the symposium. In a very special way, I forgot to recognize a very important person amongst us. This is none other but the Dean of Public Health, School Dean, Public Health from UDOM. May you please stand up so we can recognize your presence. Thank you so much for being with us. Without further ado, now that the Dean, the VC has to leave us, may I request those coming from MUHAS, as well as the UNICEF staff who are present here, to please come and stand at the back for a group picture, and then we allow the Dean to go. And as we shall be allowing the Dean to go, we shall go straight on to the partner greetings. Thank you. So for now, those working for MUHAS as well as UNICEF, may I kindly request you to come to the stage for one quick photo session, and then we shall proceed with our program. DJ, can we have a bit of background music? Can we, yes, adjust and squeeze and I would also like to recognize the presence of media houses. Thank you so much for being with us as well. Your work is needed to disseminate this information and findings from this symposium. Now we have Dean smiling more than the rest of us. This is not right. I am sure we can do better than that. Thank you so much. Thank you very much. VC, we are happy for having made time. Sorry to have taken a bit of your time this morning. Knowing that you have other competing priorities, we are honored and happy to now allow you to proceed with your other responsibilities. Can we put our hands together as the VC is proceeding? Thank you very much. May I request you all to be seated as I bring to the stage Awet from UNICEF. Please join us on the stage. And as Awet is coming, may I request, we're going now on to partner greetings. A representative from WHO to come and say a few words. And the representative from WHO will be followed by USAID. WHO. As she comes, can we put our hands together for her? Thank you very much.
Good morning. Habari za asubuhi. I thank you, MC, for the opportunity. My name's Neema Kileo. I'm from the WHO country office. At WHO, I lead the Health Promotion and Social Determinants of Health program, and I'm also the team lead for risk communication and community engagement in the context of emergencies. My role is to greet, so I'm here to greet you. By definition, a symposium is a place of learning. So I'm looking forward to learn from you and to learn with you. Asante sana UNICEF, Meza Kuu, for creating this platform for learning from each other, because when we learn, we grow. I'm a product of MUHAS, kwa hiyo I'm amidst my teachers, my mentors. I'm very excited to be here, and I'm looking forward to really strong recommendations from this important meeting. Asante.
Asante sana, WHO. You made me remember the statement, why should we stop learning if the world never stops teaching? Thank you so much. So I now have the pleasure to invite USAID to come and say a few words as she comes. Can we put our hands together for her as well? Thank you very much. USAID will be followed by a representative from CDC.
Good morning, everyone. Hope you can hear me. I'm Lulu Msangi from USAID. I'm the Social and Behavior Change Lead at USAID, overseeing integrated SBCiE activities. As Neema said, I'm also a product of MUHAS from School of Pharmacy and later School of Public Health. So I'm honored to represent USAID and to be part of community dedicated to addressing unique challenges posed by health emergencies in Tanzania. In times of crisis, the importance of social behavior change cannot be overstated. Whether we are responding to natural disasters or public health emergencies, the ability to influence positive behaviors and empower communities is paramount. USAID is committed to continue supporting SBCiE activities during public health emergencies through interventions such as support strengthening of multi-sectoral coordination of RCCE, gather social behavioral insights to identify and understand information gaps needs of the priority zoonotic diseases, support disease and implementation of multimedia campaigns for priority zoonotic diseases and other public health emergencies, and also to conduct social listening to support infodemic management. This symposium serves as a pivotal moment for us to come together, share experiences, and chart a course towards more effective SBC strategies in emergency settings. The knowledge that will be exchanged in these 3 days will have a potential to transform lives and shape the trajectory of our collective response to crisis. Our commitment to humanitarian principles and the well-being of affected populations is at the heart of our work. As we delve into discussions, let us remain focused on how we can better understand, engage, and support communities during the most challenging times. I encourage all of us to actively participate, lend your expertise, and forge connections that will strengthen our collective ability to navigate health emergencies successfully. Thank you for your dedication to the principles of humanitarian assistance and for being part of this symposium. Together we can enhance the effectiveness of SBC in emergency response and contribute to building more resilient communities. Thank you very much.
Thank you very much, USAID, and I must say, or rather remind us of the adage in Africa, if you want to go fast, go alone. But if you want to go further, you ought to go together, and this is why we have our partners with us, giving us their remarks, very insightful, setting up again the tone for this symposium. I now have the honor to invite CDC to the stage, and after CDC, I will have UNICEF giving us the opening insights. Let's put our hands together for CDC.
Thank you and good morning. Honorable chief guests, partners, colleagues, ladies and gentlemen, all protocols observed. My name is Wangechi Gatei. I'm the director of the Global Health Security Program at CDC here in Tanzania. I've been working here since 2020. And I'm really grateful and thank you to UNICEF and MUHAS for organizing this very critical symposium. CDC, we have been engaged in a lot of, like all of you, we've been engaged in a lot of the preparedness, the pandemic responses, and over the last 20 years, whether it's HIV, whether it's swine flu, whether it's the COVID-19 that we just went through, or the Ebola outbreaks that we've been responding to, we have now learned the hard way that there are some 3 critical things that you must have. The first one is human resources, people who are trained, people who have the skills in all ways, in different areas and cadres to respond. The second one is you have to have your technologies, your medical countermeasures, your medicines, your diagnostic capacities and all that. But the third one, which is the biggest and the biggest mover, is the risk communication and community engagement. No matter how many interventions you may have, if you leave behind your community, your impact will be limited. And so we have now learned that this needs to be a prerequisite. We all need to be and to have some level of risk communication and community engagement, because that is the tool you use to be able to impact social and behavioral change. And so I am actually here and talking in my personal capacity to challenge the universities to develop different programs. Let's take it, it's like driving. You know, when you have to learn to drive, it doesn't matter whether you're a professor, a doctor, you have to go to learn how to drive. You have to go and learn whether you are a captain of the plane or the ship, or you are driving a small car like me, or you are driving a 18-wheeler. You still have to go and be taught how to drive. So let us not assume we know how to do risk communication and community engagement. We may not know. And so we need to have packaged trainings so that we can all be more useful, be more impactful in the areas that we are engaging in. Whether you are in the lab, whether you are in the doctor, whether you're a nurse, whether you are a community healthcare worker, I think this is a tool that we all need. So thank you for the symposium, and we hope and pray that we all have a very productive 3 days. Thank you.
Asante sana. You've also reminded me of one of the presentations made last week in a meeting I attended. The importance and the significance of communication, okay? We can all survive when there's no electricity, probably when there's shortage of water, and sometimes food. But imagine if our mobile phones, the data and everything is switched off for at least 30 minutes. I think there will be an uproar in Tanzania. So thank you so much for that reminder that communication is very key. And now the tools that assist us to passing the information across. Distinguished participants, I now have an honor to invite the Deputy Representative of UNICEF so we can have the opening insights from UNICEF. A round of applause as he comes to the stage.
I think so. Thank you so much. I know Professor has left, but Professor Apollinaire Kamu Habua, the Vice President of Muhimbili University, MUHAS, Professor Fromense Gastro, the Dean, School of Public Health and Social Science, and also the Dean of the University of Dodoma, here present. Government representative, particularly Dr. Chipole Mpelembe from Puralj, Dr. Peter Mabwe from Ministry of Health, colleagues from United Nations agencies, USAID, CDC, civil society organizations, and academic institutions, all protocol observed. Ladies and gentlemen, habari za asubuhi. Assalamu alaikum, good morning. A warm welcome to this first symposium in Tanzania focusing on advancing social and behavioral change in emergencies, commonly named SBCiE, through high impact emergence approaches. Speaking on behalf of UNICEF, I'm honored to address you today. This symposium is a critical milestone in our joint effort to advance social behavioral change in emergencies through collaborative impact, through collaborative and impactful strategies, fostering partnerships, synergies, and knowledge management for wider implementation in this country. As we all know, Tanzania has faced in the last couple of years multiple public health emergencies, including disease outbreaks, natural disasters, such as COVID-19 that we faced, measles, polio, cholera, Marburg virus disease, MVD, anthrax, dengue fever, drought, and floods, etc. I'm just saying etc. So with all this, we know that social behavioral change in emergencies is critical to address the unique challenges and risks during these emergencies by promoting behavior like evacuation, seeking shelter, adhering to safety protocols, practicing good hygiene, accessing healthcare services, and supporting vulnerable populations. So it's really a critical component when it comes to emergencies. And UNICEF, that's why always we worked closely with government. We really thank government for that, because in all these emergencies, we have been working hand in hand with government to prepare for, prevent, and control the negative impacts of public health emergencies. And that's why we are pleased to work closely with government and also other development partners to co-lead the social behavioral change in emergencies with Ministry of Health, Health Promotion Section, and engage additional key implementing partners to support high-impact interventions during emergencies. This symposium, organized in partnership with the School of Public Health and Social Sciences at Muhimbili University of Social and Allied Science, aims at 1, sharing best practices, 2, developing capacities or exchanging capacity development, and 3, showcasing specific contribution that will aid in the advancement of this important work. The symposium also will cover other different technical areas of social and behavioral change in emergencies, such as evidence generation, dynamics of partnership and institutional inclusion, cultural nuances in Africa, scalability, sustainability, replicability, and social accountability. And I think I just want to comment on this because in the last MVD response, we've seen how our collaboration with academies, particularly Muhimbili University, was crucial to see that it has given us another way, and I think bringing in together some component of behavioral sciences. And I think we've also seen in other areas, like in DRC, for example, during the Ebola response, like the first intervention was not impactful. But when behavioral science was coming, like working with academies, with universities, having these real-time researches and evidence has been instrumental to understand the dynamic of communities and to provide the right response. Ladies and gentlemen, as we can see, this is a great opportunity to bring together traditional and non-traditional partners, which is also a great time for all of us to strengthen our collaboration beyond emergencies and around SBC. And for me, this is very timely. It's a very timely symposium because we all know that we see how it is raining now. So when it's a lot of rain, implication is floods, cholera. So all public health emergencies are around. So now we're in El Nino. We are also operating in a climate change environment, as well as other things, all the ingredients, that can bring public health emergency and so, strengthening our work. So I think this is very important and very timely. So I wanted to highlight it. That I would like to specially thank the Muhimbili University and Health and Allied Science lead for leading and championing this partnership and ensuring sustainability in knowledge management. I would thank also go specifically to government of Tanzania because nothing is possible without government leadership, and we really appreciate it. We've seen it. I think one of the speakers said it during the Marburg, how it was controlled because of government leadership. So we really thank government for acknowledging and also for leading social behavioral change in emergencies and also for working with us in these different pillars. I'm confident that this symposium will equip you with the knowledge, the skills, and inspiration to drive sustainable changes. UNICEF reaffirms its commitment to collaborate with government of Tanzania in preventing and managing public health in emergencies and fostering long-term partnership for delivery at scale. Thank you very much. Asante sana.
Thank you very much. We can do another round of applause for him for that wonderful remark. Again, so if you've noticed, what we are attempting to do this morning is basically to set the tone for the next 3 days. And distinguished guests, ladies and gentlemen, before we take a quick tea break, we could use some more insights that we ought to ponder on as we munch on our coffees and teas. Allow me now to bring a keynote, an opening keynote, which is given by Dr. Priscilla Madzinga Kusena. She is the lead, I need to read from the back, Social and Behavior Change in Emergencies, a force to be reckoned with in the world of public health, with an impressive track record in designing innovative approaches for social and behavioral change. She is true visionary in this field. Dr. Priscilla, from the leading PHEs across East, West, and Southern African countries, to developing three-tier knowledge management system. She's expertise and skills. Her expertise and skills are second to none. She is changing lives and making an impact. Ladies and gentlemen, let's give a big and warm applause to Dr. Priscilla as she comes to give us a warm keynote presentation, and then we shall break for tea to continue to dwell and contemplate on the coming 3 days. Karibu, Daktari.
Good morning, colleagues. Habari za asubuhi. Mangwanani. I'm so excited, and I'm thrilled to be speaking with you this morning, and truly humbled to be giving the opening technical keynote on behalf of UNICEF Country Office, and also on behalf of the technical organizing team. I'm so thrilled to be giving this technical keynote because what we see here today is a culmination of a lot of visionary leadership when it comes to social and behavior change in emergencies. This platform we have today is a result of the tenacity and agility when it comes to advancing key approaches that are really high impact in terms of implementing social and behavior change in emergencies. It's been a lot of hard work from the section, and it's also been a lot of support from the senior management at UNICEF, that today we are where we are. This symposium is the first ever in the country, and we are really excited as we continue to chart a lot of first ever interventions here. I think, as you can see from the title itself, being a symposium, our main aim really is to ensure that we have focused discussions around high key thematic areas, and also ensure that there is dialogue along the way among the group of participants. And in terms of the title, if you have noticed, it's not just social and behavior change in emergencies, but it is also advancing social and behavior change in emergencies. I would like to underline the word advancing because what we have done also is to chart a different path. What we have done is to use a lot of research. What we have done is to use a lot of best practices, innovations, evidence-based approaches, and also model some systems and dynamics to ensure that we continue to implement high-impact approaches. Next slide. Great. Okay, great. Yeah, so briefly, this technical keynote, I'm going to just do a brief overview, then I give the background, objectives, methodology, the key themes, and the expected outcomes of this symposium. Just to situate this symposium in what is currently going on in country, as mentioned by the previous speakers, Tanzania is also experiencing multiple emergencies, public health emergencies. This includes disease outbreaks and natural disasters. But within that context, what we have is also issues around misinformation and disinformation, issues also around community fatigue because of a lot of concurrent and multiple public health emergencies going on at the same time. So UNICEF Tanzania Country Office co-leads social and behavior change in emergencies here in Tanzania with the Ministry of Health, Health Promotion Section. But also we work very closely with other ministries to ensure that we reach as much as we can. These include the Ministry of Community Development, Gender, Women and Special Groups, as well as the President's Office, regional authorities and local government, the Prime Minister's Office, Policy, Parliament and Coordination, specifically the Disaster Management Section, the Ministry of Information, Communication, and also information technology. So as we continue to support as UNICEF social and behavior change in emergencies, core to our approaches include the continuous application of marrying and adapting scientific knowledge together with community knowledge to design social and behavior change in emergency systems that address or that have a holistic approach. As you may know that the issue of social and behavior change, especially in life-saving situations, requires really nuanced and holistic approach. So core to the technical support that we give includes adapting that scientific knowledge and community knowledge to co-create solutions with communities. And of course, the other high impact approaches you will see as we continue to unpack this symposium. What we have realized with the context that we have given and the same context that has been given by other speakers is that there are key opportunities for us to continue advancing issues around social and behavior change in emergencies by really making sure that we integrate and we also align with different partners as we continue to forge partnerships and synergies around social and behavior change. Like I've just briefly mentioned, what we started as UNICEF Tanzania Country Office is to support the partners that we work with, having a co-leadership role with the Ministry of Health, Health Promotion Section. We also have a leadership role when it comes to working with the other implementing partners. So what we began by doing is just to build capacities and then also chart the first internal joint program review. UNICEF also has about 10 implementing partners working and focusing on different technical areas when it comes to social and behavior change in emergencies. So what we did initially was to ensure that we bring the partners together, learn and also work around areas to do with partnerships and synergies. We have a thematic discussion on that. And then after that, we developed a common feedback platform where partners also could provide their feedback in terms of program implementation. And that is what culminated also into the first National Joint Program Review, where we had about 35 implementing partners attending, and that program review was done in Tanga region. So what we are continuing to do now is to ensure that we continue tightening our knowledge management framework in terms of connecting people to information, people to organizations, and people to people. That's why we actually have this symposium today, and we are so excited to be with you and to be having this platform supported by the UNICEF Tanzania Country Office. So what we have done this time around, I think if you are actually following very well, the first time it was an internal and national level, but what we have done is also to take advantage of information technology and how to bring the knowledge that we have, the best practices from Tanzania, to the global village. So the participants that are registered online, we do have a blended approach today, both physical participants and also participants online, and you can see the coverage in terms of where we are. So we started off 10 implementing partners internally, then we grew to 35 national implementing partners, and today we have about 55 implementing partners registered to attend physically. And then we also have the global village joining us. We intend to continue improving and advancing social and behavior change in emergencies. So I'll quickly take you through the objectives, which are very clear, like what the UNICEF Deputy Country Representative said in terms of ensuring that we foster collaborative partnerships. This is one of the key areas that we are working on. We are going to have a thematic discussion and note on that. And then also around issues to do with sharing insights, using different platforms, and ensuring that we also cultivate synergies. Partnership and synergies, they seem to move together, but when you look at the dynamics and the dimensions, there are some nuances, some differences there. And of course, issues around social accountability, we are also going to have a thematic note on that. So in terms of the methodology, like what we are doing now, what I really want to focus on is the session that we are going to have with the experts. We have organized a special session where participants gathered here today will have a chance to interact with the key experts, keynote speakers, with the different heavyweights around social and behavior change in emergencies. These are people that you hardly meet in the corridors and spend some time with. So we hope you are going to make use of the chance to engage with the experts. We have designated 2 rooms, auditorium downstairs, and even this one after we close our presentations so that we can engage with the experts and get more insights from them. These are the key themes which we are going to cover while we are here, and we are hoping that because it's a symposium, the discussions will be very engaging and inciting. We have done a lot of work, we have supported a lot of work around evidence generation, data, and use. I think one of the key issues being mentioned here is how we manage to adapt the usual socio-cultural anthropological surveys into response anthropology, how we have done community polling, how we have done a lot of other interesting multiple streams of evidence generation to close the data loop. So really, participants have to look forward to that session. It's going to be very enriching. And then we are also going to look at the dynamics around partnerships and synergies. How do they assist us to deliver social and behavior change in emergencies, especially moving from the normative, that emergencies, they just come and go, but how then do we look at the legacy and the system setup to drive us to strengthen that humanitarian development nexus. And then the third theme is one of the most interesting themes that we have, especially here in Tanzania, looking at the different ethnic groups, heritages and culture, even Africa as a whole. How do we continue to unveil the discourse of culture? How do we use systemic differentiation to assist us to tailor our strategies as we continue to engage and protect and deliver life-saving interventions in the community? And then the fourth theme is around scalability. I think what we want to look at also, we are going to get some experiences and practices around issues to do with scaling up results, issues to do with scaling up the footprints, what are the advantages and disadvantages, what are the experiences also in terms of the support that we have been giving here in Tanzania as partners. And last but not least, social accountability. We are going to dive deeply into issues to do with equity. How do we ensure we have institutional inclusion in the activities that we do? How do we also make sure that we remain accountable, we are held accountable when we deliver interventions in triple vulnerabilities and other issues that are happening in the community? So these are just some key areas that we are going to look at, but of course, delve more as we continue to engage with the experts. And then the last day is around also social accountability, but I think we are going to have a critical presentation there on rethinking inclusive exclusion of people with disabilities. So this is what we are expecting, colleagues, for this symposium. Knowledge sharing, I think it has already started the minute the MC introduced the symposium. We are learning as we continue to engage. We have an opportunity also for networking and collaboration. We can see the diversity that we have here, different partners coming together. There is an opportunity there to network with both the academicians and the technical leads. And then also discussion and dialogue. We hope during the moderated panel discussions, we carefully selected 5 moderated panel discussions which are going to really expound key issues for each thematic area. And then community building. We have already started, we have begun. Remember, we started as 10 implementing partners, now 35, today 55, and we have the global village. So it's sort of a roadmap towards strengthening our knowledge management strategies. And then we also have research and publications, of course. This is also going to be something that we need to look at. Then in terms of the long term, our expectations are that after this symposium, then we are going to really feed forward what we are going to learn from this symposium. We are feeding forward other than feeding back, because what we are looking at is continuous advancement as we learn the best practices, the challenges, and use them to also employ high-impact social and behavior change in emergencies approaches. And then we are also hoping that when we have dialogue and discussions, we can develop some key partnerships among the different participants here to chart the way forward as we are in a context of continuous and concurrent public health emergencies ongoing in the country. And last but not least, as an expected outcome, the advancement of knowledge itself. So colleagues, I think this is just about it. Just to mention on the fourth one, where we are really focusing on charting and strengthening knowledge management so that we continue advancing social and behavior change in emergencies. We are looking forward to the knowledge management centers and all the issues that are going to come about as a result of this. So I want to thank you so much, colleagues, and yes, asante sana, Mazita. Thank you.
Okay, I was consulting Dr. Priscilla. First, let's give a very big round of applause for that powerful presentation. I was consulting her whether we should take questions now or later. I know some of us might or must have questions, but I think let's break for tea. And since we have discussion after tea on the same topic, we shall ask questions during then. So we'll now break for tea. It's 10:13, and let's come back at exactly 10:30. Thank you very much, and enjoy your brief tea break. Thank you so much. Please take a note. Tea is served at the ground floor. Tea is served at the ground floor. We have 14 minutes left before we come back. So also to note that we have Wi-Fi. The name is Conference, which is in capital letters, and the password is Conference, lower cases. Conference, Conference.
SBCiE.com. Purchase your tracks today. Purchase your tracks today. Purchase your tracks today.
Good morning and welcome back. Good morning and welcome back.
Purchase your tracks today.
Can I confirm in the room if Professor Munondawafa is in the house, is in the room? Professor? Can I see your hand? I know you not back yet. Professor Kakoko? Kakoko? Okay, so my two speakers are here, but they've not gotten back into the venue. Let's give them 2 other minutes and then we start the program.
Purchase your tracks today. Purchase your tracks today. Purchase your tracks today.
Public Health and Social Sciences. He is a behavior change specialist and an expert in health promotion and health education. Among other things, he teaches risk communication and management in health emergencies. He has accomplished a number of consultancies, activities focusing on health, care seeking, and utilization of behavior agenda, HIV, AIDS, as well as behavior change issues. He has participated in various health interventions in the country, including the COVID-19 Vaccine Acceleration Plan 1 in 2021, and Ebola Preparedness in 2022. He has led several committees where he previously chaired the Subcommittee for Information, Education and Communication for the National AIDS Control Program under the Ministry of Health and Social Welfare, 2012 to 2017. Currently, Professor Kakoko is a focal person of Muhimbili University of Health and Allied Sciences to the Prime Minister's Office, One Health Coordination Section. Since 2019, as well as being the chairman of the Content Review Committee and the Health Promotion Section of the Ministry of Health, Community Development, Gender, Elderly and Children since 2020. Distinguished participants, A round of applause to Professor Deodatus Kakoko as he comes to the stage. Karibu sana, please take your seat. Professor Davison, you will start your presentation. You have 20 minutes. Thank you.
Yeah, I think I got it. Let's see. Yes, and you said this is next, and this is back. No, I don't think. Let's see.
That's your presentation, right?
Not yet. There is no. Yeah, now that's my presentation right there. Let me turn this off. Sorry about this. Good morning, colleagues. I have the great pleasure of joining you this morning at this very important symposium, which I am aware that has been fully introduced to all of us. So my part for now is to say all protocol observed. I've been given 20 minutes. The introduction of who I am has been done, so I'm not going back to that, but we have 2 more days ahead of us to exchange notes on who am I, what brings me here, or where am I coming from. I think there is a slight error. The presentation on the screen is not mine, but I can talk about it. I like the subject too. When you retire, you can talk about anything.
But as you do, maybe you can give us one word about yourself.
Okay. Thank you, sir. Thank you. I'm Davison Munodawafa. Let me start with the current situation. I teach at the Midland State University in Zimbabwe. I'm a professor of community medicine, and I also have another role at my institution which links very much with MOHAS, the Muhimbili University here, which I know there must be other colleagues from Muhimbili whom I would like to talk to later on. I am the partner coordinator for Midland State University and UNICEF. We work with UNICEF in a similar manner, and right now we have teams in Zimbabwe on SBCiE research. For us, it's research. Yesterday we had a conference on disabilities hosted between UNICEF and MSU. Thank you very much. I now have my presentation. And my presentation is to look at lessons that we could draw from the past in the area of public health emergencies, disease outbreaks. My interest is to look at the challenges and what opportunities lie ahead. I have anchored my presentation on the first major pandemic or disease outbreak of 1918, which is 100 years ago. So I want us to start looking at what happened during the Spanish flu in 1918. And is it resting or what? Yeah, but my screen is not showing there. It's showing there, but it's not showing on the beautiful television. Murphy's Law says if anything is to go wrong, the one that does the greatest damage will go wrong. And I am not seeing, but you are seeing my presentation, and I'm supposed to present. Yeah, I know, I think this is not very stable. It's going on and off. Anyway, let's see. Yeah, okay. Let me go from here. It's a little odd. Yes. Get me another mic, or else. You see, what happens is my good fellow professors and lecturers, they know this. They're afraid for talking, and this technology doesn't support you, you get lost. Anyway, I'm going to introduce the social and behavioral change in emergencies with the following highlights. As I said, my interest was to look at what happened 100 years ago and what lessons or what have we observed since 100 years ago and what has changed. You will be surprised to find that we still face the same challenges that were faced during the Spanish flu or influenza in 1918. The recent public health emergencies such as Ebola, COVID-19, cholera, SARS, H1N1, monkeypox, listeriosis in South Africa, they are very much linked or interrelated to what happened in the Spanish flu. A number of challenges that we faced. The challenges that we have faced in Ebola, in COVID, in SARS, are also the very same challenges that have been experienced during the 1918. Among the other issues, as we said, we are looking beyond just the public health emergencies. We are also seeing a big challenge related to other communicable and non-communicable disease interventions. Why? In particular, in the area of competing needs versus limited resources, we have the same pool of human resources to address the unfinished agenda of maternal and child, malaria, HIV and AIDS, and we have the same pool of financial resources to address that. So these are the issues that are, all right, now I see my thing is supposed to be working and it's not working. It's funny. So in the keynote presentation, I hope to just share the lessons of the past public health emergencies, and I would like us to examine the challenges and make some recommendations on going forward. I know this is a scholarly piece of work and we are all very much interested. It just gives you how some of this information was gathered, and so this you can read. I don't need to talk about it. So, looking at the social and behavioral change in emergencies using the Spanish influenza or the Spanish flu of 1918, you will notice that the Spanish flu spread from Spain, France, Great Britain, Italy, and it killed more than 50 million people. In addition, it also had huge economic consequences. If you recall, the index person or patient was identified in the US sometime around March 1918, and in May 1918, the Spanish influenza spread also to North Africa and then came down southeast and covered the whole continent of Africa. In August 1918, we had the second wave of this outbreak reported in Spain, and this is where the name Spanish flu actually began. And once the second wave came on, the discussion about where did it come from or through which door did it enter stopped, and everybody just said it is from Spain. So all Europe said that it is from Spain. And I'm sure you can relate what happened 100 years ago to say the issues around COVID-19. Some of you may be aware of what happened with the case of listeriosis in South Africa, where the listeria bacteria was found in polony, which is a special delicacy. Everybody around lunchtime, kids eat that, and when it reached lethal levels, it started killing. And the investigations around COVID-19, we know it is traced back to China, and the Chinese, you'll be aware that they were not very happy with that label that COVID started there. The issues around listeriosis as well, when the investigations were done in South Africa at the factories where this bacteria was identified, at one point it was linked to a product that was coming from Brazil, because Brazil was providing this particular product, which was a part of the polony, the meat. And definitely Brazil was not amused with that, and they fought back. Even the industry itself was also not happy to be labeled as the source of the listeria. So we're seeing a trend of things that happened in 1918 still being a part of what we are now experiencing in social and behavioral change in emergencies. So, the historical context, which I just gave, some of the things that you notice we are applying today were applied way back then in 1918. In August 1918, the first official preventative actions were implemented. These were obligatory notifications. We are supposed to notify. And these are obligatory, meaning there is an enforcement component to it. And experience has shown us that the way some of these enforcements are being done, instead of promoting SBCiE in emergencies, they are actually hindering. Because when law enforcement comes in, they are not public health experts. There were no vaccines and there were no antivirals. Only symptomatic treatments were there. And we have seen that with the most recent outbreaks, talk of COVID, H1N1. Normally, Ebola, there is no vaccine, there is nothing. So the only approach or approaches to reach the community, to slow down the outbreak and the transmission would be the issue of SBCiE in emergencies. And that's what links us 100 years ago. We still are on the same protocol. We're just coming out of COVID, and I know you're all aware of what happened with the vaccines. Finally, the good part is that that science has advanced so much that we are able to at least get a vaccine out. But the issues that are related to the vaccines, as we will discuss later, or including the issue on vaccine hesitance. What were some of the SBCiE in emergencies 100 years ago? Well, there was street cleaning, disinfection of public spaces, such as churches, workshops, and theaters, wherever people were crowding, and we are doing that today. The banning of crowds outside shops, limiting the number of passengers in a public transport, limiting the movement of human beings. We do that, and we've done that even with the COVID and the other recent outbreaks. And these were done 100 years ago. That's what they have, and that's what we still have. The difference, I'm sure I will agree, is the way now we are trying to do it. It's going to be a little, it's now different. The distribution of free soap, clean water, removal of human waste, all these were done 100 years ago. So, I'll go on to just highlight a few things around Ebola, so you can see how it relates also to what happened with the Spanish flu. The virus was discovered in 1976 in the Ebola River region of the Congo. And it was established because of the good work now with our epidemiologists, the technical people that we need so much in SBCiE, in emergencies, that the symptoms will appear 2 to 21 days. And this is critical because then we know how to package our responses. There is currently also no proven cure for Ebola, but there are vaccines that have been given and will continue to be given. Case detection, isolation, infection prevention and control, and risk communication, community engagement, the SBCiE component, have now been incorporated, and they are part of the package also for Ebola. Disease management focused on containing symptoms, and vaccine trials were initiated. So this is, again, a departure point from 100 years of the Spanish flu. We're seeing a more aggressive and interest in vaccine trials. The countries in West Africa, Sierra Leone, Liberia, and Guinea, 2014, 2016, for those who may be forgetting, that's the period we are talking about. The last cases in Ebola was 2018 in Congo. So, what are some of the issues that we have seen on the situation with Ebola? As we have seen that they were obligatory. In 1918, the law also came into effect. There were obligatory measures that were put in place to contain the outbreak. We're seeing that with Ebola in 2014. The WHO also taking this to the World Health Assembly, to their group of scientists, and to declare this a public health emergency of international concern. And this is what now is the terminology we use to situate in what direction outbreaks are headed. During that epidemic, EVD spread, okay, that's just the background of the Ebola thing. The secondary infection were mostly in Nigeria and the US. And one of the lessons that came out from the long history of our association with the outbreaks is that training on risk communication, community engagement, which I said houses the SBCiE in emergencies, was now being done live in the field. That capacity strengthening was being now done live in the field. Laboratory capacity, we started seeing laboratory capacity on the increase in the 3 affected countries, and we had a very weak surveillance system, which is all linked to the health systems being strengthened. So this is some of the things that have now come out of the Ebola experiences. I quickly talk about COVID, and I think this is something which is all on our minds. We still are interacting with COVID in one way or another. This was identified in the city of Wuhan in China, and that statement of identifying it in Wuhan has very rich implication in SBCiE, because China and whoever will have been implicated in this case is not going to receive it in the positive. The virus spread worldwide by early 2020, and the World Health Organization, as you well know, in January 2020, it declared it a health emergency of international concern. Was then also on the 5th of May 2023 declared a non-threatening condition. COVID is ranked the 5th deadliest epidemic in the history. It killed more than 6 million. I've just been told here I have 5 minutes, but it took 1 minute when I was walking here, so make sure you adjust your watch. So the impact, we are at a level now where we are watching very closely what were the impact of COVID-19. Misinformation through the social media and mass media. The pandemic brought to the forefront issues of social justice and equity when we discuss the issues around vaccine. And you will recall in those interested in reading in this area of distributive justice, the social scientists in the area of distributive justice make a very clear argument. If you participate in developing something, you should also participate in its benefit. And they were in the African region where countries were participating in vaccine trials. But come time for the vaccines to be distributed to benefit the African region and other regions, we saw that there was an inequitable distribution of these and there were racial, geographic, political tensions, public health interests versus individual rights, the disruption in systems such as education and the health system. All these are experiences that link very clearly and in a strong way, though negatively, to the work that we are doing in SBCiE for in emergencies. Okay, so to sort of wrap up what I'm trying to say here, 100 years ago, the more things change, the more they remain the same. We continue to experience similar challenges. From the 1918 Spanish influenza to COVID, we are still using law enforcement to realize our intended goals. In a number of these pandemics, and I've seen in cholera, in COVID, in Ebola, when we're doing contact tracing, we ended up actually roping in the military, the army, the military and the police. Now we are even roping in the IT people because we also want to catch the contacts. But is this the direction that the SBCiE is now going to move? And if we are going to move, what is it that we should be bringing to those partners whom we need very critically to help? I remember in IT, because contacts were missing, but they would be making phone calls, and IT can help you find whoever is making a phone call. Law enforcement, some of the contacts were not very friendly to the health staff. They became very violent, so you need them. But the manner in which they interacted with public health and communities did not produce the kind of results we wanted. Then comes the issue of the press. I've talked about the press as our third state or fourth estate, right? They are very important, and I was happy to hear the press being acknowledged here. But it got to a point in 1918 where the press was being asked by their press handlers, the states, to report in a certain way and to keep certain information away from the public. And we have seen that in Ebola, we have seen that in COVID, we see that in cholera. So this is something that we need to think about as we try to expand the role of social and behavioral change in emergencies. How are we going to prepare our colleagues who come in with all good intentions to work with us? Government media houses also need this reorientation. Censorship was not limited only to information, but it was also limited to comments. There are times where people cannot speak publicly, although we tend to encourage from the academia and that you are free to speak, but sometimes you are not free after you speak, so you have to be very careful. Okay, say, can you just 1 minute so that I leave this stage feeling good that I've done what I thought I came here to do. The media also stopped broadcasting news about outbreaks that I've mentioned. Restriction in the movement of the people became a major concern, and we continue to see this 100 years later. The role of culture was downplayed throughout disease outbreaks, and basically culture was seen in the negative, and yet there are positive aspects in the culture that needs to be part of the intervention. The issue of vaccine uptake, hesitance, and resistance, we have seen that there was a lot of misinformation, disinformation that went out and made people fear or unwilling to take vaccines. So the inadequate funding is a major issue. We cannot continue with SBCiE in emergencies when funds are not directly injected into this area of work. So again, as I said, there are competing interests, the issue of coordination and management, and the issue of evidence. Did it work? If it did, how did we do it? And I think this is also an area that SBCiE, many of us feel we have an emotional attachment to it. We really like it. But when we meet with other peers and with other groups and donors, they want to know the value of their money, and we don't have that evidence. And I think this is an area where we need to start moving aggressively. That if we are going to print so many pamphlets, if we're going to reach villages and communities through radio, does that make a difference? Is that money worth putting into that? So we must think seriously about that. And the realistic opportunity, the building the resilient health system is an opportunity. Political will is an opportunity we should ride. Our leadership, they'll go to the UN, New York, they go to the smallest village, and they put their arms around COVID and any outbreak. So let's take them on that. Strengthening the role of media, we need to do that. So leadership, partnership, being able to negotiate, and being able to review and revise. These are issues that I think we should look at when we think of good governance for health. Yeah, those I think we have already covered. So the issue on the multi-sectoral, the required actions, the segmentation, I think these are all the issues that we are all very much interested in. And there are some references for all of us to also work on. But let me thank you again, and I realize that we have to rest a little bit, but it's good that we can draw lessons from 100 years ago. Are we still swatting the same fly, or the situation has changed? I want to think that we are swatting the same fly. We have really not gotten out of the blocks 100 years from 100 years. And the worst fear any public health person has now is not about COVID-19, but it's about the next outbreak. And if I could have anyone who's looking through the glass or the whatever to tell us what the next outbreak will look like, then we will be very fortunate. But it's good that we are preparing now for that next outbreak, even if we don't know what it is going to be. I thank you very much. Chair.
Professor, please take it. Another round of applause for Professor. Asante sana. Before I bring Kakoko onto the podium, and technology is failing me. Before I bring Professor Kakoko on the podium, and I was thinking and going through notes that Professor has just presented, I was contemplating on the fact that building and maintaining public trust in a crisis, how critical and pertinent this process is. Professor, as you rightly put and took us through some critical examples from back in the days. I was imagining if you're in an aeroplane, you're already seated, and then 5, 10, 15 minutes, you've not taken off, nothing, there's no communication. That feeling. And I'm contemplating now, you know, the way passengers in an aircraft would be thinking and imagining what is going on, why there's no communication, who are we waiting for, what is going on. Similarly, this could happen when there's a crisis, when there's an outbreak. So we need to continue to engage and see how best. I believe there will be so many questions to Professor before I bring Professor Kakoko as well, on how then we can build and maintain public trust in crisis, including the aspects of multiple communication from experts. But again, I leave this all up to us to decide and ponder on as we navigate through the day. I am happy now to invite Professor Kakoko, who will take us through, again, as I mentioned earlier, what he has prepared for us on behavioral sciences and its application, the use of social-cultural anthropology to bridge the evidence loop in the SBCiE. Professor Karibu, you have 20 minutes.
Yeah, thank you, Mr. Chair. Really, I'm honored to get this opportunity to make this presentation on behavioral sciences and its application. And this is on the use of social-cultural anthropology to bridge the evidence loop in social and behavior change in emergencies. Really, this is a timely talk as far as different epidemics are concerned, and it's just after we conducted a study on Ebola preparedness, and therefore I believe this is the first time. Okay. Yeah, this is the first time when we are making this this presentation after that study that we conducted. So welcome you all to this presentation, and I'm going to be as brief as possible, but really there are key issues that we may wish to take with us from this presentation that I'll be highlighting at the end. And it's very important that this topic is being discussed, aspects of social and behavior change, because as everybody was saying since the morning, this is an important aspect when it comes to emergencies. And everybody gave the testimony of different epidemics and pandemics, and the recent one being that of COVID-19 pandemic that affected all of us globally. If we could have a lot of time, we could discuss and everybody could give a testimony on what happened amidst or in the context of COVID-19. I remember I have been teaching different aspects of social and behavior change, but I became a novice student when it came to COVID-19, when I was challenged by some of the aspects when it came to how could we handle some aspects of COVID-19. But the Ebola outbreak in Uganda, the neighboring country, also we took some lessons because there are no boundaries to say Uganda to Tanzania. The only effort was there are different efforts including aspects of behavior change. So regions like Kagera, which was nearby Uganda, was very much prepared. I led the team that went in Mwanza for Ebola preparedness. And I really learned a lot of aspects in terms of Ebola preparedness when I led the Mwanza team. And I think we have a lot to do in terms of that. But the recent Marburg in Kanyangereko and the other villages in Bukoba was also another lesson. And we learned a lot, and perhaps we need to get prepared. The former presenter said, there are more than this, and nobody knows what's going to come the next, but the next is coming. When? It's a big question. I told members of the district council in Bukoba, a week before they faced Marburg, I told them the same statement that something's coming. The day it happened, they asked me, how did you know? I told them that I didn't know, but I predicted. And we still predict something might be coming in the near future. Focusing on social and behavioral change is paramount. We know that this is the first line for the defense to slow emergencies. This is especially in the context of infectious diseases. And importantly, social and behavioral change should be a participatory process that involves partnership and cooperation among different stakeholders. It's no one's job. It should be done by different partners to make sure that within the context of emergencies, we all work together. And to work together, there are three aspects. The first one being collaboration. People need to work collaboratively. It's different people, different teams, different disciplines. Now, how do you work together? You need to collaborate. And people, in terms of collaboration, working together in that particular context. So collaboration should be the first keyword. But there is also, if you collaborate, you need to coordinate. There must be coordination somewhere, whether it's at the higher, the middle, the lower level, but people should be coordinated in context of emergencies. But the third one is communication. People should communicate. Effective communication is key in context of health emergency. So it's very important to make sure that we get prepared for the 3 C's: collaboration, coordination, and the communication. My talk is going to focus on behavioral sciences. This is my home, this is my department, this is my life. But looking at its application, of course, as university dawns, we are happy of talking, teaching, researching on behavioral sciences, but the challenge comes when it comes to application. How do we apply these aspects in the real sense of the life? How do you apply them in context of emergencies? Behavioral sciences, the field of study that serves to understand human behaviors. And human behavior is something complex. Really, as human creatures, we are a bit complex. Everybody here is complex. And the behavioral sciences try to go inside and see these different aspects of human behaviors. Before I became a health psychologist, people used to I used to think like everybody else, that a psychologist, when looking at you, they may see even your ideas. That's never on earth. There are no such a psychologist unless there's a witch. It's only human actions and human interactions that may entail the human behavior. I may not understand you. If you sit there, don't talk to me, you don't interact with me, I may not understand you well. Sometimes as psychologists, we tend even to provoke people. If I provoke you, I come to understand you well, than just sitting and gazing at you. So we are doing much more on aspects of actions and interactions, especially when it comes to social psychology. And knowledge of human behavior is, in this context of emergence, critically important when it comes to aspects of prevention, preparedness, and response. This is especially during healthy emergencies. We need to get to prevent the diseases before they occur. How do we go about, and this is automatic, things like cholera and the other infectious diseases which have something to do with the human behavior, as previous speakers said, but we need to get prepared. Sometimes things get worse. If you drive, you say that you prevent the accident, but you need to get prepared if it's going to happen. But ultimately, you respond. It has happened. How are we going to go about? Then ultimately, we have to respond to such emergence. So it's through the knowledge of behavioral sciences when we need to get to prevent, get prepared, and respond to the diseases. The context of this symposium is much more on behavioral aspects, but social and behavior change, in addition to aspect of communication, social and behavior change communication, are critically important in these aspects. And they stand at the top list of interventions during healthy emergencies. Due to the focus on first, they deal with the social as well as behavioral aspects. In this context, I should illustrate that behavior change is our ultimate focus. And that has something to do with the healthy education. We normally inform people, we normally teach people, we communicate with the people about healthy aspects as well as healthy risks. But it's contemporary to put it as the social and behavior change because of the social component. If you tend to educate people without helping them to, without putting the context to which these people can change their behavior, that becomes futile. It's very important to ensure that the context, and this is where WHO came up with the understanding of the focus of health promotion at the process of enabling people increase control of their health. So you need to put the context to which people can control different aspects of their health. So the term social is critically important in that way because it people to use condoms, but condoms are not available, condoms are not accessible, they cannot afford the condoms. Put the context to which these people, yes, they understand the importance of condoms, but do they have the context to which they can use the condom? That's critically important. So this is the first aspect of that parameter. Then the second one, through the use of information, education, and the communication. Social behavior change communication brings about change of knowledge, attitude, and the praxis. We have seen a lot of studies focusing, we call them CAP studies, looking at knowledge, attitudes, and the praxis. Now, to entail that in the context of social and behavior change, we need to put more efforts on information, education, and communication. We realize, like the previous speaker said, during the COVID, you realize we had a lot of IC materials trying to reach people. Like Peter Mabwe is here from the health promotion section. I work with him closely. And most of the time, we look at these contexts of those IC materials, how can we use them to change, for the people to get information so that the information helps them to change their behavior. Understanding that knowledge is important, though not sufficient for behavior change. But the most critical aspect in the behavioral sciences is dwelling on models and the theories of behavior change, which inform behavior change, which informs social and behavior change interventions, and particularly during the emergencies. It's critically important, as everybody said, to have evidence, and one of the evidence area is on use models and the theories. These are the complex areas. Sometimes when you introduce them to the students, sometimes they see them as complex phenomena, but they're critically important to inform the processes. I understand, and I remember all during the COVID, I was summoned to attend one of the big meetings, the workshop in Dodoma, where I was supposed to talk about how can these models and the theories help in terms of uptake of COVID vaccine. You remember in those good days, we had introduced COVID vaccine, but after some weeks, only around 300,000 vaccines had been taken. So which was about 1/3. People are not taking the vaccines. But the question was, why not? There are good reasons for people not taking the vaccines. Sometimes as experts, we just tend to blame people. The blame should be on our part. We are not doing just. What should we do? So they asked me to talk about the models and the theories. How can we use them so that the uptake of the vaccines is informed by the models and the theories. So those models, some of which talk about the level of individuals, some of which talk about the stages of behavior change. You cannot tell people to take the vaccines and immediately they take them. They have a lot of questions they ask themselves. So through the steps, then they come to accept it. So there are different models and the theories. It takes some days to talk about them. My former students like Neema, Kireo, and the others would interpret that, I think, later, how those models perhaps have helped them in terms of their enactment of SBCiE, for example, in that particular context. Critically, behavior change should be evidence-based. That's perhaps the key message. Should be evidence-based. Now, this is interred in our evidence of social anthropological study that we conducted in different regions in Tanzania, and that study was meant for Ebola preparedness. Because if it happens, Tanzania has a case that has been reported, we need to know how are we going to handle it. It has not been reported in Tanzania, ever. But if it's reported, what are we going to do? So those were the regions, Kagera, Mwanza, Kigoma, Songwe, and in Zanzibar, mjini Magharibi and Kaskazini A, and these were the areas where we conducted our study. And these are some of the highlights from the social anthropological study. We used that to gather the evidence. You cannot have an effective social behavior change if you don't have the evidence. You need to have the evidence on how to go about it. And we use anthropological approach because we believe that we wanted to go to the communities, get the depth of the communities, get the depth of understanding. You go to understand the why of why. And some of the key findings are on the care of sick patients. How do we care the whole process? How can it be infectious? Death-related practices. There are a lot of practices related to the death. For example, one of which is shaking hands. Some of the cultural context, they tell you without shaking hands, then you have not consoled that family. There are a lot of communal practices, eating together, drinking together. There are social practices, such as handshaking, hugging, and religious and other traditional practices. This is just the segment of the information, but we got a lot of information in telling about social cultural practices for Ebola transmission. Now, what are the key issues from our findings that may at least corroborate efforts for social and behavior change? One of it is transmission and prevention practices, social practices, operate at different levels. Some are global, some are regional, some are cultural specific. And we need to understand that before we come up with that kind of intervention. For example, handshaking is the global. Whatever the country, in USA, I believe it's the same. It's the handshaking practices are there. But the second one, identifying social cultural practices is necessary, though not sufficient. Before social cultural anthropology research, we believe that social cultural anthropology research provides some room to understand the depth of the meaning that the community attach to such cultural practices. For some of the communities, everything they do has social meaning. Now, when you come to the interventions telling people, stop shaking hands. So sometimes we tend to tell people, don't do this, and we come with a lot of don'ts. But we need to do research to understand why are they doing so, and how can we communicate in those particular contexts. So it's very important to generate such evidence to make sure that they inform the practices and the interventions. The key messages to this presentation, I highlight some of the key three major things. That social cultural anthropology research is crucial in securing information for preparedness of health emergencies. They should be done before health emergencies occur. Let us not wait for Ebola to get the first case of Ebola in our country. Let us do these efforts. Let us correct a lot of evidence. Let us understand this meaning. When Ebola happens, we need to have that information. Otherwise, we are going to suffer the consequence. The second, social and behavior change communication have to be evidence-based. That should be informed by field data as we learned from the field. And the third, there is a need for tailored and the culture-specific information and messages during healthy emergencies. One shoe cannot fit all. Sometimes we tend to have the messages, Mabwe and the others, we have been discussing this, where we tend to bring up the messages that we think that can fit across the whole country of Tanzania. That's not when you go to the Haya, when you go to the Nyakyusa, when you go to the Skuma, they have specific culture. In Zanzibar, they have their own practices that perhaps we may wish to understand beforehand. In conclusion, behavior change in health emergencies is challenging, as it requires individuals to abandon familiar and adopt potentially unfamiliar practices. We live, we learn culture, we acquire culture. Really, we don't even learn culture. Culture is normally acquired. It's cultural acquisition. Sometimes people think that we learn. Learning is a formal process. We just acquire them. We absorb them. And we used to live with them. Then when you have done so, it's like you tell me not to shake a hand during Ebola, during COVID. Really, it's difficult for me because it's a part of my cultural practice. I meet somebody, I shake a hand. Then you tell me not to shake a hand. So really, it's one of the big challenges because we deal with what people have acquired at the party of their life. It's difficult to make people unlearn what they have learned. It's a process of making people unlearn because they used to do that. The way it's a part of the culture, the part of the parcel of their culture. So this is my key message, that for those dealing with the social and behavior change communication, let us get that information, let's get the evidence, but we need to get prepared and we need to learn, keep on learning. How do we make people unlearn what they have learned? This is one of the references that we may wish to read. Let's connect with the expert session. During expert session, I recommend that we read Health Communication Capacity Collaborative, Social and Behavior Change Communication for Emergency Preparedness Implementation Toolkit. Thank you for being part of this symposium, and we look forward for you contributing your experiences. Thank you very much.
Asante sana. Another round of applause to Professor Kakoko. I'm now going to open the floor for questions, and as I do that, Professor Kakoko, in a very special way, you've opened up a new horizon of thoughts to me as well as a communication practitioner. One of the examples you've used is when you tell people, you communicate to people and anticipate that people revert back in the same manner or way that you anticipate them to do. But again, looking onto the communication, and the good example that you've used is with HIV and AIDS. You tell people to use condom, but then are condoms available? Are condoms affordable? Are they accessible? So communication is one thing. The application or putting into practice the message that comes across now depends on various many other factors. So totally appreciated, and we shall continue to learn. So the floor is open now. Do you have any question to either of the professors? But I would also like to say, is Priscilla still with us? Priscilla? Doctor? Okay, we shall retain a question until further. So just for, you will have to lift your mic up first and direct it to you, and then you put it on. Don't put it on before it is directed to you. It's written speak. This is when you press, and then you can ask your question. So there's the hand at the far left. Karibu, yes. I think for the purpose of photography, may I request you to please stand. So don't put it on before you direct it to you first. But yeah, it's on already, so please start talking. This is to avoid, you hear that sound? When the mic is close to the speaker under it, it makes that, it's called feedback. So please proceed. If you may stand up, introduce yourself, and go straight into your question.
Well, thank you so much for having this opportunity to ask a few questions. But before I ask, maybe moderator could have let us know where maybe we can have a submission for other questions because of time. Because, for example, for my side, I have like 2 to 3 questions, so I don't ask all of them. But the presentation was good. But when I came here, I see this message, ensuring the scalability and the sustainability and the applicability. So my first question, it's when I was listening to the speaker, I wasn't yet to hear about the issue of inclusivity, accessibility, especially for marginalized groups in our integrated program, and what is our strategy to incorporate. My second question is, I just want to understand how does this social behavior change leverage or integrate the community-based initiatives which are within in our context, particularly Tanzania, or within our community. My last question is, as far as sustainability concerned, how do we foster the sustainable community when it comes to participations and the ownership of the program throughout, not even the pandemic or the these emergency diseases arise or come to our end. Thank you, and let me stop there.
Thank you very much. I will take 2 more hands. If there are any of the professors can respond to your question. Yes, madam. Yes, ma'am. Yes. Thank you so much. And please remember you can switch off your mic now, gentlemen. Thank you. Please remember to introduce yourself and go straight into the questions.
Thank you very much. My name is Redempta Mbatia. I'm a medical doctor, and I'm leading a public health institution working with the government. So my question is to thank you also for the presentations, very insightful. I have 2 quick questions. First of all, to Professor Moom. Sorry, I cannot get your name right. I don't want to make a mistake.
Professor Wafa. He's allowed you to say to call him Professor Wafa, but we're not calling him Professor Wafa because he's still so much alive. Ushers, can we have the mic to our participant, please?
How to ensure that risk communication and community engagement, which entails involving the health and community systems. How can we actually work with the government to ensure that we take advantage of the strategies that are in place? For example, I know the government is now towards ensuring we have a community health workforce, many of them. So I'm just wondering, how can we as people who care about social and behavior change in emergency take advantage of that? This can go to any of the two presenters. When we talk about the next epidemic, we are just thinking mainly, which is really fair, of the infectious diseases, communicable diseases. But we know we are having, if you ask me, epidemics of non-communicable diseases. And I would like to understand, how can we maximize? This is something we are living with. How can we maximize using social and behavior change to ensure that we also address that? Thank you.
Thank you very much. Wonderful question. Yes, gentlemen, over to you. Right under the mic, there's a button that says speak, I think. Yes, there you go.
Trying to stand up.
Please try. If you will fail to stand up, then there'll be no lunch for you.
I always struggle for it. Good morning. I'm Egidius Kamanyi from University of Dar es Salaam. Thank you for the presenters. That's very insightful. I have a comment on Professor Kakoko's presentation, which is very important, the anthropological approach to understanding the behavior change in emergent situations. It happens that the area you have mentioned, at least in Kagera, is one of the areas that I've worked on, especially on disaster management. And one thing that I have learned from the area is what we could call usugu wa tabia. There is, I don't know how to put that in English. I mean, people have been used to disasters, to crises, to the extent that they no longer kind of, have hope of a difference. In one way, in terms of how they have ended the crisis, in terms of prevention, response, and the process on the recovery. And my main comment is on the recovery process, which informs how people, respond in terms of behavior for the next disaster. There is one area that you have mentioned, which historically has faced a lot of disasters and, emergencies, if you want. That is Misenyi district. Looking at the trajectory of disasters in Kagera, almost 5 disasters have completely, dismantled that area. Starting from the 1970s, it was the area where the Uganda-Tanzania war under Idi Amin, started, and it did not actually start there. We see it in 1978, 79. That's what it is in history, but they started all the troubles all the way from 1960s, 1970s. And you remember when Mwalimu Nyerere announced the war, he said, nia tunayo, sababu tunayo, na uwezo tunao. So when you try to understand those words, like we have the reasons to fight, we have the abilities to fight, and we can do it. So what were the reasons? When you go back, you see those people suffered atrocities. Husbands saw their wives being raped, children being raped. I mean, people coming up and looting, plundering before announcing the war. 8 years later, then the war was announced to rescue them from the atrocities. Okay, putting that aside, HIV/AIDS, which we think came all the way from Uganda, it started in the same area because it is at the border. Misenyi is at the border between Tanzania and Uganda. And then that's HIV/AIDS. After that, we witnessed again, there is business between Kampala, Tanzania, and then all the way to Bukoba through the lake to Mwanza, you know. And now we had MV Bukoba capsize in 1996. It had a lot of families suffering the atrocities again from the same area and the other parts. I would mention more and more, but you know, all the way to the earthquake. So when you look at the history of those people, there is a lot of, you know, a lot of stories coming out. One important thing is the recovery. What is ever done to recover these people, to give them some kind of hope for tomorrow? Every time there is an emergency, every time there is, you know, a disaster, there is never a complete recovery. When I went there back in 2017, for my PhD actually, when I talked to those communities, which was anthropological in nature, people are no longer expecting a difference. You ask them, they say, okay, this is our life, this is what we are used to, and we can still survive it. So the change we want to talk about in emergency situation is together with the people losing hope, people no longer having trust, people not even listening when it comes to, you know, to the government, for instance, putting in place certain, you know, announcements, certain prevention, you know, guidelines, even the WHO guidelines, for example, for COVID-19. They are sometimes not even being practiced. The Marburg, they are not being practiced. Even other guidelines. Why? Because people say, okay, this has been happening to us. We never see anybody coming to us and change anything.
As you wind up.
I'm winding up, and I'm not trying to cast blames. Like the government is not doing anything. They're doing a lot. They're doing a lot. But how does it entail people giving value to what that is being done to them? So when we talk of behavior change, I think an individual, as a person, beyond institutional revamp, is something that we need to discuss in this. Probably, Professor Kakoko, you might need to throw some light on that. Thank you.
Very
Chair.
pertinent. Thank you so much. We'll take the final hand at the back. Yes, Karibu. If there'll be any further questions, we'll take a second set of questions, but for now we'll allow, after her question, we'll allow our two presenters to respond to this will be the 7th or 8th question asked. Karibu.
Asante sana. Thank you very much to all professors for the very good presentation and helpful to us. My name is Dr. Ndeniria Swai from Dar es Salaam Regional Office of Health. I'm a research coordinator there. I would like to ask both professors concerning the presentation they have given us. To me, I take it as a preparedness now for the outbreak. Any outbreak, it is applicable. How did you figure out the governance and the public administration during outbreak? How can you figure it out? I wanted to see the issue of global health system reliance during encounters of the stress. As you know, there are the stakeholders to respond to the outbreaks are many, but there are key stakeholders. Taking the example of health workers, taking the example of social workers, and health officers. You know, the health workers, meaning the doctors and nurses, they go to school, to medical school, but they don't think about the outbreak. It's just like somebody who is pulling the rope. When you are pulling the rope, you pull to your direction, not outwards. Now, most of the health workers, when they go to medical school, they don't think that they are going to respond to the outbreak. They think that they are going to help people during emergency or disease. But in the case of the outbreak like COVID and the like, it's like you are going to respond to the outbreak, but also you are putting yourself in a chain. And this made more of the health workers to get burnout. People, they got burnout. People were so much stressed. I don't know if tomorrow I'm going to be infected or what. Sometimes the PPE are not there, but you are there as a front liners to go and respond to the outbreak. the health workers, the health officers as well. They thought that they are just there to go for maybe there is a flood or whatever. But at the time of COVID, they found that they are now going there to rescue people. They are now going there to fumigate, and they are at the risk. The same to social affairs. They thought that they are there maybe to solve the conflict within the families. But for the time of the outbreak, like COVID, they found themselves that they are going there to the infectious area. So I just want to know, how did you found the governance and the public administration in case of things like this? How can we figure out this? Because we are going to get another outbreak. How will you go around? Thank you very much.
Asante sana, and that marks the last but one question. I would like to also pose a question to you, professors, believing that I have the permission. Any of you can speak and respond to my question. Professor Wafwa, you had mentioned on the aspects of risk, but Professor Kakoko, you had mentioned on the anthropological aspects. I'm looking into communications ethics. At what juncture do we have then to speak the truth, even if we know that truth in communication can cost us? We have witnessed, given the case of COVID-19, whereby I think one of the reasons why the campaigns were not very successful, or probably the number went up to 6 million plus, was because of inconsistency in messages. I will cite one or two examples for the case of Tanzania. There are an aspect of the masks. Were they able to prevent the transmission or not? The vaccination, if you're vaccinated, were you safer to transmit, not to to transmit or not to transmit, to contract or not to contract? Aspects of such. So while we know what lies behind any communication that we cut across the aspects of risks, hence the truth has to be bent. But as far as communication needs to remain ethical, at what juncture do we decide then this needs to remain ethical, or this is for the public good? Over to you, my professors, and then I will invite Alicia to come and give us a new highlight of technology in communication to as far as information system and AI is concerned. Professors.
Yeah, really, thank you very much for your good questions. I make a highlight of some of the key things. Professor Wafe is also going to add some few grains of salt in the pot later. But I should say all of the questions are pertinent, and these are the issues that we feel and think that we should be able to answer in the particular context. We are all struggling. Yes, to see whether we can struggle and get out of this pond. And really, I think it's very important. Somebody said that even getting the other way of getting more answers, clarifications, I think organizers are going to devise the means, but it's very important that we discuss and address these aspects. And we are also going to learn from you when it comes of these other aspects. Really, the issue of inclusivity and the accessibility of the information is critically important. There are different segments of the populations, and we have different people. I remember during the COVID-19 campaign, when I was going around the country, people were asking, how do you regard some of the groups? Do you think that they are going to access the information or not? Of course, given the time, perhaps you couldn't cover everything, but this is critically important. With the social and behavior change, we need to consider different groups. How do we communicate with those groups? Some people who cannot go to the campaigns, we sometimes that we go to to the town centers doing the campaigns, but some people reach those areas. Really, they are just an example, but there are different populations that we may need to take them. So social behavior change should take into consideration different strategies that we may use. So just I can accept that, but it's also a part of the discussion. How we foster sustainability of the programs of interventions. Of course, the concept of partnership goes, people think partnership is for MUHAS to partner with UNICEF. That's a part of it. It's more than that. We may have partnership with the communities. Good universities, and normally even challenge my university, good universities have areas, for example, where they can learn, where they can take their students to learn. We have the communities, go ask here my dean, the School of Public Health. We have the communities along coast region where our medical students go to learn, they interact with the communities. So that's the kind of partnership that we may get. But at the end of the day, the issue of sustainability in terms of the behavior is critically important, the question, but it's another gray area. How do we do? What do we do? This is another area that we can ask ourselves. What do we do? It needs evidence, it needs some sort of research to ensure that behaviors are sustainable. From the theoretical point of view, behavior tend to lapse. People who are protecting themselves may no longer protect themselves. And again, they have good reasons. It's upon us researchers to do research and they understand why do these people behave the way they are behaving. So the issue of sustainability also deserves a new look, and how do we sustain our interventions? We know it very well. During COVID-19, people were washing hands. There are a lot of struggles. The question, when we look at it now, is that really happening? Do we have water somewhere outside where people can wash their hands? Are we observing some of the things we are observing? And that's why you see, I was reading yesterday, cholera is coming up, and is coming up relentlessly. During COVID, we also changed the way cholera, but cholera is coming. Why? These are the questions of sustenance. Coming to the issue of, Dr. Mbatia said the next epidemic, of course, she made a challenge on addressing infectious diseases, that most of the focus was on infectious diseases. Really, I agree that we focus more on infectious diseases, but non-communicable diseases have a lot to do with the human behaviors, sedentary life. And that's why, as Mr. Chair said, that you ask the question when you are standing up. And that's to make you stand up and stretch. In health promotion, we don't even entertain to putting toilets nearby. You need to have a distant toilets so that you walk and go. It's a health promotion in practice. People may say, it's too far. It's not too far. You need to walk. Make sure that at least. So really, we need to have a focus, because both infectious and non-infectious diseases have an aspects of human behavior. So really, it's because of the short term, but with more time, we can dwell on the other aspects of non-communicable diseases, which are also, we have double burden of the diseases, especially in developing countries. Egidu Siaman talked about usugu wa tabia. Really, he talked in length about that and what happens in Kagera. And I'm sure somebody soon will be writing perhaps about Kagera as the center, because it looks like it's an epicenter. Everything coming is Kagera. What's happening? It's Kagera. Sometimes people rhetorically ask, what's wrong with the Kagera? Is there anything wrong with the Kagera? Really, there is nothing wrong, I tend to believe. It's because of some region, might be geographical reasons, on the other particular reasons. But the outcomes of the behaviors, as Dr. Amani said, really, those are the outcomes of the behaviors. From the psychological point of view, people may develop either resilience or they may despair. People may develop resilience with the problem. When you get a lot of problems, it's like the biology of infectious diseases. The body that normally tends to get attacks may develop the resilience. A body that doesn't get a lot of attack may not develop resilience. So it's like human behavior. So they may either develop resilience of the problem they are facing, or they may ultimately despair. And that's why the ministry has psychosocial support programs during emergencies. They have the programs, they have the guidelines. Fortunately, I participated in developing that guideline. Psychosocial support during the emergencies. It's a matter of implementing that to make sure that these people are comfortable. But what you said is pertinent, and we have to, it's another gray area where our partners may at least try to have a look at. The issue of preparedness and governance, I said, fortunately, I was a part of Ebola preparedness teams when Ebola was reported in Uganda. I led a team of Mwanza, and really, I learned a lot. I went away from the classes. You see at the universities, we tend to make lectures, you teach a lot of theories, you teach a lot of things, but when you go to the really practice in the field, you find things are not the same as you are teaching people in the class. You get a lot of challenges, and you get challenged. So looking at Mwanza, when I was looking at the preparedness, I realized that there are a lot of things that we should be able to work on. Of course, governance structures, Dr. Swai, governance structures are there. The day I arrived, I realized they had some groups, the teams, subcommittees, they are working, but coming to the reality was a bit challenging. When I started walking around looking how were they prepared to respond. Mwanza, fortunately, for example, has the Busweru Center, which was built with the support of funds, I think, from WHO for the Ebola preparedness. But looking at that center, you realize a lot of challenges. It wasn't even, there are a lot of challenges which are in that context that we may wish to address before Ebola, not during Ebola. And that's why what we said is correct. We didn't find even the health workers over there. The list of health workers to be there was already, but people did not want to go there. They had a lot of fear, they had a lot of worries. So I was wondering if the first case could have been reported. I don't know whether they could run away from that center and they could resign even from the employment, because they had a lot of fear. This is another area that we should work on, ensuring how we get our workers prepared and help them to get rid of the burnout and the stresses, as you have said. So the structures are there, but you have to work more, especially when it comes to health workers who are supposed to provide the services. Anthropological research, when do we speak the truth?
Yes. Okay, that's the last question. Thank you.
The last question, when do we speak of the truth? It's difficult to speak the truth, as you said, because yes, truth is there, but you need to know when to speak the truth. We normally speak the truth, but at the right time, not at the wrong time. In risky communication, normally don't promise, don't say anything unless you have evidence. Get prepared. That's why in risky communication, we tend to believe that you tell people that, yes, this is the problem, but we are correcting the information. We are looking what type of the problem. With any disease, a rare disease, then get prepared to tell them that what you are searching, what you are looking, so that at the right time you communicate the right information, but not when you are not prepared. Thank you very much.
Thank you so much. A round of applause to Professor Kakoko. Professor, ethics in communication is pertinent. I will come back to that. I will bilateralize that with you maybe over lunch, but over to you, Professor Wafwa. Thank you.
Okay. Okay, thank you very much, and I want to thank also Professor Kakoko for taking all the questions I think head on. I just would like also to try and answer. I may not go question to question, but when I was listening carefully to the line of questioning that was coming up, I could pick that there is a thread around social and behavioral change, that there are questions that are coming up that need to be addressed, the fundamental ones. As I looked at the 100 years with you, I also, I'm sure MC, the slides or the presentation we prepared will be given out, right? I have on slide 16, it was far towards the very far end, where I was talking about the strategies and the required actions. I didn't really give it the time, but never mind, the question time helps me. What I think, I looked at the issue on integration. I think there was a question around integration. How do you plan to, I didn't hear about integration. Then there was a question around the role of government. What have you been trying, or how can we work with the government? There is an issue around how to ensure that RCC is working, or this was the issue on government. And the other one had to do with the areas of other non-emergencies, that public health issues that are non-emergent but requires SBCiE as well. Then on the role of government, I think there was a talk around the healthcare workers, the burnout, and I think those are very key issues. Let me start by responding to the issue on the healthcare workers. It is true, we have limited numbers of healthcare workers out there who have the necessary requisites of the content and the skills to actually go on the forefront. When it gets to emergencies, not very many people would like to be on the forefront. Emergencies are not like your ordinary public health issues where everybody can become an expert overnight with malaria, diabetes, hypertension. Everybody claims to know something. But when the Ebola outbreak in 2014 was declared and WHO had to deploy, I was head of program coordinator for the Africa region for RCCE in Congo Brazzaville. And the regional director called us for a forum in the big assembly and said, I'm going to deploy some of you. You are aware of what is going on. As WHO, this is one of those moments we have to do what we said we are going to do. So I'm going to deploy some of you to the front. Guinea, Sierra Leone, Liberia. And I'm reading out their names. So he started reading those names. And my name was there. On about, I think, August or so, we found ourselves on a plane to Liberia. I was in Liberia from July 2014 and came back in October. And I want to share with you what you said about the burnout. You talk about burnout, but it's late. It's late if we are going to diagnose or discover that our healthcare workers have burnout. We should try and find them at the time of brownout. Before you burn out, you brown out. Those who are familiar with cooking, a lot of things start changing color. Yes, we were there in the front, and it really affected health manpower. I'd never lived in a place for 3 months just with my hands like this. So when we were sent back and when Ebola was finally, declared over, the regional director, as part of therapy and as part of also keeping us sane, was to send us back to Liberia and start shaking hands. We went back to shake hands. This is not a fairy story. But it's very important because the biggest resource any organization has is its human beings. So we need to think around SBCiE and the health manpower that we are likely to deploy in times of crisis and those that can do the regular work. Integration. Yes, we need to think. Now, this brings us back to the framing. We need to start rethinking or revisiting the framing of SBCiE, whether it's in emergencies or just social and behavioral change as it is. We need to start thinking around the reframing. Why is it important? Well, the issues that we are now facing, as much as we are talking of emergencies, UNICEF, its mandate is on children. And I think I'm right, unless I've moved to another zone. But the UNICEF I work with every day are working with children. And if you look at that population and that group of young people, from whatever age group we are talking, up to 24, whichever bracket there, they have a huge potential, and they also suffer negatively during these public health emergencies. And if we don't have the mechanisms, how many of us here can do data collection with children? Most of us, when we were going to school, all our assessment, needs assessment, rapid assessment, what assessment, was just to work with adults. But I'm coordinating a project right now in Zimbabwe with UNICEF, and I've learned quite a lot. And you know, when you start learning when you have retired, something is very exciting. We're looking at, say, open defecation. People don't use toilets, latrines. Children, adults, and all that. And we're going to the villages. Why is open defecation an issue for SBCiE? It is an issue because when you start looking at cholera, the end part is we are complaining and reporting cholera, and yet cholera requires two things. Fecal matter that's contaminated, it requires water. And people are washing hands or eating from water that's contaminated and all that. Yet we want to direct our people to go and use toilets. If you're going to do your needs assessment and just talk to adults and not find out from children, but how do you interview those children? Take, for example, the issue on climate change. We're talking of now saying we need to understand our mitigation strategies, our interventions on climate. But the children are a major part of that movement. If they don't appreciate what we're trying to do in the area of climate change, we will not succeed with just the adults. Because you're talking of energy, every family sends the child to go and bring firewood. And they don't know, they think it's their job. So they'll go and cut all the trees and bring firewood home. So I think this is why we need a reframing of our SBCiE. There's a lot of contamination, but he sends you home and he asks you tomorrow, how are you? Say, oh, I slept okay, but I still have a headache. He gives you more Panadol. So the question of the commission was, why do practitioners send people back to the conditions that made them sick in the first place? So the key to that is we need now to do more in-depth understanding on the living conditions. We need to understand the living conditions of our people before we can just try and solve their problems. And most of us are not trained in that area. We don't even know where these people are coming from. And I think SBCiE, before we can go to the howlers, to the radios, to the television, we should be in a position to describe exactly the conditions in which people are born, live, grow, work, and die, and Google. We need to be confident to know that. So that for me, and we also need to understand the policies that have been put in place. These policies produce health outcomes. Most of us grew up thinking the Ministry of Health produces health. It doesn't. The ministry tries to fix health. The other ministries and somewhere else is messing up with the health of the people. But until we know the imperative mandates of education, the imperative mandate of Minister of Gender, the imperative mandate of Minister of Agriculture, we will not be able to bring them back to communicate the messages we want to communicate.
Prof, as you wind up.
Yes.
Thank you.
So, yes, I think Jas was going to bring me to the media and communication. I think we need to work with government Government obviously is in a different business. Their interest in communication is to ensure that we don't cause despondence, we don't cause alarm. If you read the report on the 100 years ago in the Spanish, where they gagged the media was they did not want people to panic.
Thank you. 20 minutes.
Okay. Okay. Good afternoon, everyone. Good afternoon. It's afternoon, right? Yes. My name is Elisha Simon Magia. One day I will be a professor. But thank you for the wish. Yes, so today I'm going to speak on the role of artificial intelligence in driving positive social behavioral communications, especially in the case of emergencies. So, SBCiE in emergency response represents a very important role in not only safeguarding the lives, but also in mitigating the far-reaching impacts of disasters and crises. At its core, SBCiE has two critical components, which are effective communication and behavioral change. Now, especially in times of crises, the ability for us to convey information clearly and persuade individuals to make a positive change, it helps us to adopt safer practices, and this is really, really important. Now, we all know about AI. AI is a game-changing innovation that has come to play, and by embracing AI's capabilities, we open doors to a new era of data-driven insights and creative and innovative solutions that can transform the effectiveness and reach of our SBC communication efforts. And so as we dive deeper today in today's discussion, we will explore the multifaceted ways in which AI can elevate our efforts, showcasing its potential to revolutionize not only how we respond to emergencies, but also how we connect with, and also how we prepare ourselves in case of crises. So the versatility of AI opens a very, very diverse array of applications within social behavioral change in emergencies, providing dynamic solutions tailored to the complex nature of emergency scenarios. There is no one particular formula. One shoe doesn't fit all. We do constantly have to adapt accordingly due to the nature of the emergency. However, there are many different tools, and today we would like to highlight just some of these solutions that are particularly relevant to us today as practitioners of social behavioral change communications in emergencies. One of these tools is natural language processing, NLP. NLP is one of AI's biggest key contributions. I think most of us here today are familiar with ChatGPT. Yes? How many of us use ChatGPT to make emails, develop, improve, refine data? Yes, Tupo? Safi. So natural language processing is essentially a factor or a facet in computer science, and more specifically artificial intelligence, which concerns the ability for computers to understand, comprehend text and speech, text and words in the same way that humans can. Of course, it being a computer, it does do this a little bit faster, quicker, more efficiently, and it is able to process much larger forms of data. So using AI, not only are we able to understand, but we're also able to effectively analyze and respond to the myriad of crisis communication messages that can emerge during emergencies. This empowers us, of course, to grasp the ever-evolving needs and sentiments of the affected communities. Another thing that AI equips us with is predictive analytics. You know, predictive analytics is a formidable tool in optimizing our response strategies. By looking at past data, current trends, predictive analytics enables us to be able to make informed decisions about what might happen in the near future. Another facet of AI lies in image analysis. Image analysis enables us to assess the impact of behavioral change communications visually by providing a comprehensive understanding of their effectiveness. Through image analysis, we can gauge the extent to which communities are adopting safer practices. Basically, what this means is what people are sharing online, we can use that as information to understand better if people are adopting these practices or not. Also to understand better if there's any kind of misinformation that we need to tackle or address. And last but not least, real-world impact. So there are many concrete examples of how AI can help us drive solutions that include sentiment analysis of social media during emergencies, allowing us to communicate and respond accordingly. Additionally, AI-powered chatbots are able to deliver real-time, accurate information to affected populations, bridging crucial communication gaps during critical times. So I'd like to provide a couple of examples. So for instance, at UNICEF, we have embraced the power of AI and technology, especially within the efforts of driving positive behavioral change. Just to mention a few of the tools and innovation that we use at UNICEF, we have one tool, for instance, that's called UReport. UReport is a behavioral channel that uses chatbot and AI that enables us to run polls and surveys to young people within the age group of 13 to 24 years of age. And for instance, currently we have over 300,000 active UReporters who essentially report on the different things that are going around in their lives based off how we communicate to them. We communicate to them specifically through SMS and WhatsApp. And we communicate to them on different subjects such as sexual reproductive health, mental health, menstrual health, sexual reproductive health, and in this particular context, crises. So that's UReport. Additionally, at UNICEF, we have tools that enable us to do social listening. For instance, we use a tool called TalkWalker, and TalkWalker basically enables us to do social listening. So for instance, in the case of an emergency, we are now equipped and we are able to embrace the power of AI to really find out what people are saying about a particular thing. So for instance, if we have, we know there are talks about El Nino, so we can use a tool like TalkWalker to be able to find out what people are saying online about it. What are their fears? What do they care the most about? What kind of activities or conversations are happening around that particular subject? Another tool that we have is IOGT. IOGT is the Internet of Good Things. IOGT is kind of like a build-up on what UReport is, in that not only is it able to run polls and surveys, but we are also able to educate people for free through long format content. This is things like games, things like articles, videos, audio, etc. And more recently, we have been able to launch a game. This game is called Cranky Uncle. And for instance, Cranky Uncle is a game that uses the inoculation theory, which essentially, think of it like a vaccine for the mind. There's a lot of misinformation out there, and we can either tackle misinformation by sharing the right information, or we can tackle misinformation for young people by equipping them with the ability to be able to identify potential misinformation. And this is done through a series of tricks that have been identified that cut across different kinds of scenarios. So imagine a scenario whereby before the next time we do an emergency communication campaign or effort or intervention, before we launch this campaign, we'd run a poll on UReport. So we reach out to these young people, we ask them a series of questions, and they can answer these questions using WhatsApp, or they can answer these questions using their mobile phones. Additionally, we collect data. Before we launch the campaign, we collect data by doing social listening. When we get online, we go across all these channels, Facebook, Instagram, Twitter, WhatsApp, Google, search, YouTube, etc. And we really find out what people are saying about the particular topic that we are about to address. And after we have this data, and we have these polls and surveys, and we launch the campaign, and we're communicating on mass media, so mass media being on ground, TV, radio, etc., but also online, we can also use a channel like IOGT to really, really dive deep into educating people what this is, why it's happening, what it means to you, how you can protect yourself and your loved ones, and the role that you can play in this particular crisis or emergency. Additionally, we can run data-driven, or we have the opportunity to collect data and teach young people about different subjects using games, such as Cranky Uncle. So this is all just an example of one of the ways, for instance, that we are already trying to harness and embrace the power of AI to enable us to be more impactful and connect better with people by having real-time data, having real feedback from the people that we intend to communicate with, and embracing the power of these AI tools to drive positive social behavioral change in emergencies. So what are the benefits of AI? I might have preempted myself here, but some of these benefits are rapid data analysis and insights. With the use of AI algorithms and AI tools such as ChatGPT, we are able to swiftly process large amounts of information, cutting through the noise and really distilling critical insights that inform decision-making efficiently. And of course, because it's a bot, it's a tool, it's technology, it does enable us to do this faster, more efficiently, and potentially more impactful. Another benefit is enhanced preparedness and response. Like I said before, with predictive analytics, AI empowers us to enhance our preparedness and response strategies by analyzing historical data, current trends, and forecasting potential threats. The foresight enables measures that mitigate the risk and optimize the resource allocation during emergencies. Another particular big benefit of AI is, of course, scalability and cost effectiveness. AI-driven solutions inherently possess the ability to automate tasks. Automation means what? Automation means we don't sleep. Automation means 24 hours, 24/7, we can constantly collect data and automate tasks that enable us to communicate more impactfully and also be able to measure the impact, reach, and awareness of our communication efforts. And last but not least, personalized communication. AI's capacity for personalized communication is transformative. It allows us to tailor messages and interventions to the specific needs and preferences of affected populations. By speaking directly to individual concerns and cultural nuances, we foster a deeper connection, increasing the likelihood of behavior change and resilience building. So there's basically a lot of opportunity that can happen if we as SBCiE practitioners embrace the power of AI. Because yes, there are individuals who may have limited access to technology, but AI is not just about the use of social media. AI is about the use of technology and innovation to be able to not only collect data better, we're able to understand data better, large forms of data better. We're able to do this more quickly, and we're also able to analyze as well as do monitoring and evaluation post-campaign efforts. Of course, with anything that is new and innovative, we do have to be careful and be considerate about how to go about using these particular tools ethically in ways that don't cause no harm. So some ethical considerations are, even when we have the power to use AI, there should be consideration for data privacy and security in AI-driven SBCiE efforts. For instance, with all the tools that we use at UNICEF, the data for all the users is protected. Everybody's 100% anonymous, and nobody can actually access the data of a particular individual who said, yes, I've had sex before, yes, I've never had sex before. another ethical consideration is addressing bias and ensuring fairness in AI algorithms. This is something that is growing, but this is something that is definitely a discussion around all AI users on what are the best ways to address this bias and ensure there's fairness in the algorithms. Another one is transparency in decision-making processes. For future directions, we want to think about developing guidelines and regulations for responsible AI usage in emergencies. We want to think about exploring advanced AI-driven chatbots for crisis counseling, right? Because right now we're able to do polls, surveys, which means essentially we're able to collect data. We're also able to develop games that young people can play, which essentially enables us to educate them in ways that are fun and entertaining and engaging, and they win points, they win prizes, they get these colorful things on their images. But another cool evolution that we should be aiming for is the ability to use AI-driven chatbots for crisis counseling, because sometimes when we run these behavioral change campaigns, we do get questions about, okay, so this has happened, what do I do? How can you help me? And currently, of course, we work with, HPS, we work with Afya Call Center, we redirect them there, but eventually we should be able to help these people right there and then when they're asking for this particular piece of information. Another thing that is a future direction for consideration is enhancing early warning systems using AI and machine learning. So for instance, because we're able to do social listening, we are able to put parameters in place that can enable us to quickly identify when there's a particular rumor, especially if it's a misinformation rumor that is going on online, and so we can tackle it and address it accordingly. And last but not least, encourage collaboration among stakeholders to advance AI's role in SBCiE. Thank you. If there are any questions. Okay.
Thank you so much, Alicia, and another round of applause to him, please. I know a couple of people who have walked away with murder because of AI, and my skepticism, my fear, my concerns, my anxiety onto the world that we're looking onto is now embracing AI in communicating health-related issues. This is where we're going to decide the authenticity of communication that comes, and especially that relates to health-related topics. But again, I'm not an expert. You are, and we have the audience. Should there be any question, it is now or forever hold your peace. Karibu. Your good name and your question.
Very good presentation. It's very eye-opening. My name is Alusungu Ngailo from AMREF. I'm a stakeholder on the event-based surveillance, on the early warning and detection of public health events of international concern. Learning about the IEI, I wonder if we can use this to enhance especially on the detection of the public health emergencies, especially the novel emergencies like the new diseases that are emerging, and people, they have to detect early and report so that they can be responded early. And this is the challenge. Even in the MVD, there was late detection and reporting of that emergency. So I'm wondering if that can be used, and if you can work with the stakeholders to create
Very nice question. You've captured it very well. I will take, if there are any other questions. Well, I am not sure if we've understood so much, or our minds have already diverted to the following program. But I will now let Alicia respond to that, and then I will ask you questions from AI-related presentation. Thank you. Alicia.
Thank you for the question. So
understand your question, you're asking if we can use AI to do detection as well as reporting.
Yes, to educate the community, to enhance their agencies. We see that the SBCiE messages, they are teaching the community on how to respond in terms of crises. But when it comes to the emergence of new public health events, the community have to detect and report urgently. Yes, immediately. So we lack that urgency in the community. So can we use this model?
And maybe just to add up to that wonderful question again, you only have one question, lucky for you. Is it 2 or 3 weeks ago in Rwanda, we had a discussion there discussing on to how AI can be used to enhance climatic changes and help foster actions towards mitigation of climatic changes. And I think our question is related to this. How then can we enhance AI in communicating, in detecting, and in taking early measures to outbreaks, for instance? Thank you.
So to answer both of your questions, I want you to think about it as not enhancing AI, but rather using AI to enhance your efforts. So for instance, we can use AI to do predictive analysis. And predictive analysis, how? By looking at past data. And basically, because AI has the ability to kind of go through very large formats of data quickly, we're able to make more informed decisions much more quickly, because AI has the power that enables us to be able, maybe a job that used to take 4 weeks can happen in 2 hours or 30 minutes. So we can use AI to be on top of our game by using the features of AI that enable us to really, really analyze data quickly. And when we're able to analyze data quickly, we're also able to be prepared to communicate effectively.
I learned last week, there are 2 hands. Please go ahead. Thank you so much. I learned last week there are 3 things that are obviously very inevitable. They ought to occur whether we like it or not. One is death. Death is inevitable. The other one is taxes. We ought to pay taxes whether we like it or not. And the final one is technology, and AI, as is said, is an enabler. Karibu.
Asante sana. I'm Deniria Swai again. Thank you very much for this presentation. I would like to know about the AI on research point of view and involving the children. Who is consenting to them? How is the consent made to them? Thank you.
Alicia?
So there's 2 questions there. With regards to research, how do we use AI with regards to research? Basically, AI can enable us to do research at a wider scale and more efficiently than ever before. And this is due to the tools that are available as well as automation. With regards to consent, there are different ways to go about this. But one of the most obvious ways and more standard ways is through privacy policies that people are able to basically read and understand how their data is protected. And for those who are under 18 years of age, they would have a parent or an elder consent on their behalf. Yes.
Asante sana. If there's any final hand, I do not see any hand. So let's give Alicia another round of applause for a wonderful presentation. I believe Alicia is still with us. Please stand up, you take a picture. Is still with us for the rest of the day. I understand you'll not be here tomorrow, but should you want to engage, discuss further, then this is the time. It is now 2 minutes after 1 p.m. Let's break for lunch and come back at exactly 2 o'clock. Thank you so much. Bon appetit. Mlo mwema na mchana mwema. Let's break for lunch. DJ? So since no one has stood up, I think we'll probably take another presentation. What do you think? Should we take another presentation? Let's go for lunch. Thank you very much. So those. Hello, hello. Hello. So those who missed their badges and registered their names, your badges are ready. Please collect your badge. It could be your ticket for lunch. Thank you.
Mastalima. Mastalima.
DJ. Hello? Can I have the voice? Volume up? Can I have the volume up? Hello, 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 hello. Hello? Hello? Is this up enough? Is this up enough? Good afternoon and welcome back. Good afternoon and welcome back. Good afternoon. Yes, and welcome back. Is it good to be back? Please tell your neighbor it's good to be back. So before I bring back to the stage Dr. Priscilla, Priscilla, are you an MD or PhD or both? PhD. Okay. So before I bring back Dr. Priscilla, it being a session after lunch, I think we probably need to, and you guys are the expert on this, before we start having people contemplating more on the topic before it's presented, I think it's good that we reduce some of the food we've eaten by a very simple song and a dance move, yeah? Good thing and the beauty about communication is it keeps us engaged, it keeps us, you know, going. I believe Professor Wafwa will agree with me. With communication, there's no growing old. So when we were just finishing lunch, Professor Wafwa asked me, do we have Diamond Platinum in the house? And I said, he's going to be the dancer for Diamond Platinum now, okay? So can I request all of us to please stand up? We're gonna do some dance moves, eh? All you need to do is just follow me, but make sure you have enough leg space. We're gonna do sideways. Mostly it's gonna be sideways. There are people still standing, there are people holding their laptops. You want to be as free as a bird, ready to fly. Professor, utakaposimama tu namleta Diamond ukumbini. Okay, so we're going to do a bit of some dance moves just to, you know, energize us as we get into the new session. This is going to be about 4 to 5 minutes. DJ? So you... There's some people who think when we have sessions like this, we can't have fun, eh? So please embrace, we're gonna have a couple of other dancing sessions as the time goes back. But for now, let's put our hands together and invite to speak to us Dr. Priscilla. Let's put our hands together for him. A round of applause. So Dr. Priscilla is going to talk to us on the dynamics of partnerships and synergies synergies to steer SBCiE for scale, depth, and replicability during PHEs. Okay, very important. And just before she speaks, I would also like to say one thing about Dr. Daktari. I'm trying to see, I will probably say that after you finish your presentation. So for now, you have a few minutes. Over to you. Karibu.
I'm using this. Asante MC. Habari za mchana. Good afternoon, colleagues. Masikati. We have a global audience which can resonate with the different languages. So we are trying to adapt. So I'm going to take you through the dynamics and dimensions of partnerships and synergies to steer and deliver social and behavior change in emergencies for replicability and scalability. So what I'm going to briefly do is to give an overview, why partnerships and synergies, dynamics and dimensions, stakeholders and partnerships, synergy mapping, and limitations. But I think the team that's displaying is showing the wrong presentation. Can you please correct that? You got it? No, this is not the correct one. Yeah, because there's something, what is happening, colleagues? This is not the one. Yeah, that's not the one, because there's something very important on the actual one that I need to start with. Evelyn? Terence, I need the correct one, yeah. All right, so maybe I can, you want me to go ahead? Okay.
As we wait for the presentation, which should be coming any second now, what I'd wanted to say earlier on is Dr. Priscilla's design approach prioritizes high-impact public health interventions for replicability, scalability, and sustainability. And this is what basically she's coming to talk to us about. Aside from delivering the opening keynote, she's hosting a session now on the significance of partnership and synergies in achieving depth, scale, and replicability during public health emergencies. Seize this chance to gain insights from an accomplished expert in this field. Just also to add, as I'd asked her, is she an MD or a PhD? So Dr. Priscilla Madzinga Kusena holds a PhD in public health, MDS, MPA, BSc, PGC, com development, monitoring and evaluation, ethics and research, global MBA in view. And this is just to name a list. So when we have gurus and experts like in the house, we really need to celebrate that the symposium like this is really going to enrich and add values to our day-to-day activities. So we're ready for you, Professor, when you are. And if any of us had questions from a previous presentation, we are allowed to then ask her then. But let's again, as I had mentioned earlier, that we use this opportunity to gain a lot of insights from such young yet accomplished player we have in the room. I would also like, as we wait to start, recognize those coming from Zanzibar. May I request wale wote tuliotoka Zanzibar tusimame, so we recognize your presence. Those from Zanzibar, naomba tuwapigie makofi mengi. Tunashukuru sana, na nafahamu kwamba kuna baadhi yetu wametoka wizarani, si ndio? Na wengine tumetoka chuo. Nadhani tuna dean, Dean wa Suza au ni chuo gani? Nyinyi watatu kutoka? Ministry of Health, and then Ministry of Education, Second Vice President's Office, Second Vice President's Office. Can we again give them a big round of applause? Tunashukuru sana. Please take your seats. Truly appreciate your presence with us. How are we doing? Dr. Priscilla, are we good to proceed? So as we wait, I'm told another 1 or 2 minutes, the slides will be ready. I understand that some of us are seated here with varied backgrounds, and this is why when we are given the opportunity, I would really wish to express where you come from, so that apart from just gaining insights and knowledge and exchange from this session, we also know we can bring synergies. This is what Dr. Priscilla is coming to speak about, synergies. But again, if you have a candle, or if you are a candle and you hide it, we can't really enjoy the light that emanates from you. So I will continue to recognize those present so that we can build those strong synergies and forge away strong communication in this field. It's really challenging. May I request those working for the Ministry of Health, Ministry of President's Office, Behavioural, those present, please stand up so we can know you. Those with the Ministry of Health. Anybody else? Are you from the Ministry of Health or Behavioural? Ministry of Health. Do we have, we have, and I like the way you've positioned yourself. You know, you sit from the back and you observe and watch everything else that's going on. Can we please put our hands together for those working with the government? Thank you very much. She is also with Behavioural, and she will have a panel to moderate right after this. Anyone from the private sector? Anyone working with the private sector? So if you work in a private practice that is not affiliated with the government, can we also please stand up? Those of us in the private sector? No one. Are you from the private sector? Fantastic. Can you please stand up? May I know where you come from? Sorry? In the NGOs, yes, the non-governmental organizations, the civil society organization, those of us not working directly with, not working or not part of the public sector. We're working with the government, guiding the government, but not employed, not in the government system. Yeah, the number is increasing. You see, when it comes to communication and it's clear, then it becomes much more better. So we're all in the CBO and NG. Yeah? Thank you so much. Can we put our hands together for them? A round of applause. Thank you very much. We recognize your very big contribution in this area, and we really thank you for being here with us. Doctor, are we ready? Over to you.
All right, thank you so much, MC. So, colleagues, good afternoon once again. I will quickly take you through our experience here in terms of development, dynamics, and dimensions around partnerships and synergies, how we have managed to do it, and what are the best practices coming from our implementation activities. It's not moving. The slides are not moving. After all the dancing, we can't get the slides to move.
Apologies, technology is failing us. I think we need medical intervention in the technology so that we're able to cope up. So we are going to go on to the next session, which was supposed to be enriched by this presentation, and unfortunately the presentation is, the technology is failing us. But I'm happy to bring to the stage she was on the stage earlier, but she dodged passing the remarks. Ladies and gentlemen, allow me to invite to the stage Dr. Chipole Mpelembe. A round of applause as she comes down to the stage. What can I say about her? I do not know. All that I know about Dr. Chi, as we all know her like that, is she works with Behavioural, the President's Office, regional administration, and local governments. And she is, yes, she is jovial. So let's put our hands together for her as she takes the stage. She will then invite her speakers. Probably before she does that, Doctor, please do us the honor of introducing yourself. Tell us a little bit about yourself, and then bring to the stage your speakers, and then we shall proceed from there onwards. It's 2:30. Karibu.
Thank you very much, MC. Good afternoon. Good afternoon. Thank you. My name's Chipole Yusuf Mpelembe. I'm a health system specialist from TAMISEMI, as he has introduced me. So I'm here to moderate a panel, a moderated panel discussion on issues of partnership. And it's very unfortunate that we have not been able to, have a good presentation on this one, because the moderated panel discussion was supposed to be following up on that. So our panel discussion is titled Sharing Experiences and Best Practices on Partnerships and Synergies in Social Behavior Change in Emergencies. And then we'll have a Q&A on high impact partnerships. So participants of the panel, moderated panel discussions are experts who are in here, and these are experts. I will name them, of course, and introduce them to you, but I just want to tell you that these are people who have been working in this area, the SBCiE area, the RCC area, financial experts, health systems experts, health policy experts who have been working in the industry for years and have been having significant contributions. So it's going to be a very interesting moderated panel discussion because they're going to share with us their experience in this field and other fields and disciplines. We are going to have a lot of experiences shared, a lot of lessons shared, and examples of interventions that have worked very well, opportunities in terms of the partnership. We are looking forward into discussing synergies, what are the challenges, and looking into the future, what are the experts' recommendations. We'll then have an opportunity they will have an opportunity to interact with you, members of the floor, through a Q&A, and of course they will have a lot of time, enough time to give us their views, their insights and experiences through pre-designed sets of questions, to sort of probe them. So, ladies and gentlemen, if you allow me, I'll now call the panelists on stage. I'll start with Ms. Lulu Msangi. Please welcome to the stage. Ms. Lulu is a public health specialist and SBCiE lead from USAID. Karibu sana, Lulu. The second one is Dr. Peter Mbuji. Dr. Peter Mbuji, welcome to the stage. Dr. Peter Mbuji is a senior consultant, global health security agenda consultant from CDC. You're very welcome, Dr. Mbuji. Another one is Miss Jaliet Rangi from WHO. Thank you very much. She's here on time. So Jaliet Rangi is a SBCiE RCC expert, from a senior RCC officer from WHO Tanzania country office. Karibu sana Jaliet, welcome to the stage. And then we have Mr. Peter Mabwe. Karibu sana kaka Peter Mabwe. Peter Mabwe is a senior officer, SBCiE lead from Ministry of Health Promotion Section. Thank you very much, Kaka Peter. He's representing Assistant Director, Health Promotion Section, Ministry of Health. May I also call to the stage Dr. Rutasha Dadi. Dr. Rutasha is a guru. He's a registered health systems and public health policy practitioner. He is now working as an independent consultant, and one interesting thing that connects to our more moderated panel discussion today is that currently he's working on non-state actors for health coordination framework. So this relates to our context here. Karibu sana Dr. Rutasha. Another guru we are going to have on stage is Dr. Yahya Ipuge. Karibu sana Dr. Ipuge, independent consultant, senior public health specialist. He has worked with donor organizations. Some of the donors are here. He has also worked for instance, the World Bank. Karibu sana Dr. Ipuge. The next one is Miss Lilian Masui. Lilian, karibu sana from Ministry of Community Development, Gender, Women and Special Groups. Karibu sana. Karibu sana Lilian. Lilian is a senior social welfare officer. She's currently coordinating MHPSS, mental health and psychosocial support issues. We had a concern in the morning from Dr. Kamanyi that we tend to forget people who face or those who suffer from our public health emergency or emergencies in general, the natural disasters and so forth. So she's a champion in that MHPSS, and we would love to hear from her. Thank you very much, Lily. Our final panelist is Dr. Stephen Kibusi. Karibu sana, Dr. Kibusi. Dr. Kibusi is a senior lecturer and currently Dean of School of Public Health, University of Dodoma. Karibu sana, Dr. Kibusi. He will be representing our colleagues from the academia. Welcome to the stage, Dr. Kibusi. We would love to hear from you. Your view and insights on partnerships and synergies. Asante sana, Dr. Kibusi. So, colleagues, like I said, we are going to have a very structured discussion. As soon as Dr. Kibusi is seated, I will go directly to start interacting with my panelists. So, we all may be wondering here when it comes to partnerships and synergies and, you know, connecting for impactful SBC. What do we really mean? What are the main issues? What are the main drivers behind the dynamics of partnerships? What drives partnerships? And as we all know, that SBC is a field that focuses on using communication strategies to promote positive social and behavioral outcomes during emergencies, whether they are medical emergencies, public health emergencies, or natural disasters. But what are the drivers that are behind this? So may I please call in Dada Lulu from USAID to give us insights on this one. Dada Lulu, Karibu, you're first on this. Can you use the mic on the tables, or if you can use the one from your neighbor? Peter, can you share your mic? Yeah, that's on. Karibu.
Can you hear me? Yeah. So good afternoon, everyone, and I'm happy to be one of the panelists in this important discussion, and I'm happy because I was involved in some of the emergencies which came out in Tanzania, from COVID-19 to Marburg, and so as part of the stakeholders in supporting SBCiE, doing the drivers will be a good opportunity for me. So I think to start with, the number one thing which I see is key and that drives this partnership is strong government leadership. So by government leadership here, we mean host government leadership, because sometimes we forget and we think we are everything. But here we mean Ministry of Health, all responsible ministries. I shouldn't want to mention and forget others, which are also key and important. So when emergency strikes, so having a strong leadership is key to make sure information gets out to the people, the right information at the right time to inform people what needs to get there. Not only that, but also getting quickly the estimation what is required to overcome the emergency. So with the strong leadership from here, I will speak much on Ministry of Health as the mother ministry. Then we saw a lot of activities moving quickly on surveillance, on what needs to be done, if it's the test, now talking of Marburg, what budget is needed for SBCiE for different activities, what tests are needed. So we really saw that from the government of Tanzania, from the Ministry of Health. So that one really drives everything. Then number two is collaboration. So collaboration of all state actors, like all the stakeholders in place. So again, through the Ministry of Health, calling upon all the partners who are responsible and making sure we collaborate together and bring inputs on the table of what needs to be done exactly to quickly alleviate the situation. This goes also with coordination. How best do we work together as teams? So that is also another thing which is key in driving, making sure that we have the right information in place to inform what is the right communication that needs to go out to the people, because most of the times, for example, looking at the Marburg, when it first came out, everyone thought it was Ebola, Ebola, Ebola. So how best can we alleviate the myth and misinformation from the people? So really need to coordinate together and come up with quick information to send out. Then multi-sector engagement at all levels now. From the national level, now moving to a regional level, then at the regional level, we move down to the community level, to the district level, making sure everyone is involved, from the partners to CSOs in the regions, so making sure like everyone is pulled in and involved. Then do we have enough resources? With resources here, I'm not talking of money. Money will come very late. But do we have enough expertise at different levels to make sure they respond to the crisis which comes at hand? So that's talking of expertise, enough expertise at different requirements, and to make sure we inform the decisions that need to be made. Then after that, do we have data to inform whatever decision that we need to make? So do we have data in place? How quickly can we move the data? Then we can have the data, but do we have expertise who can manage now, analyze the data and give sense out of the data so that decisions can be made quickly? Because here we're talking of emergencies. which means also decisions needs to be made quickly. Then now resources comes in terms of funding. So how best can we quickly pull in resources from different stakeholders? Because, for example, we have Government of Tanzania. What is the ministry bringing on the table from the government side? Then partners quickly to make decisions on how much are we bringing in, because in the first place, when we talk about government leadership, they've already shared with us, for example, an estimated budget. So through that budget, then each partner to say, do we have enough? How much can we pull as quick as possible so that the teams can go and continue with mobilization, with communication, so that people can get the right information. So I think quickly from me, I'll stop there, and I don't want to finish everything, but strong leadership, collaboration, coordination, and Professor Kakoko spoke about those: collaboration, communication, and coordination, and then making sure we have the expertise, the right expertise, and I'm happy that we have academics in the room, where most of the time we run to them to get their views and understanding, and quickly we go and alleviate that. So I can speak quickly, for example, during the COVID-19, with the disease, I think it was easy, but the challenge was mainly during when the country introduced vaccine. A lot was said on the safety, a lot of misinformation came, so we really needed a strong SBCiE intervention to make sure that we remove all the wrong information, making sure people understand about the safety. And I remember by then we pulled people from different sectors. Even I remember in some meetings we used TBS, we used NIMRI for them to come and share how safe the vaccine is. And then when the communication came out, the strategy was out and materials developed, they had the information which people wanted to hear. It wasn't easy, but again, looking at the coordination which was put by the government, we were able at least to make sure people are vaccinated and reduce the infection. Thank you.
Much Lulu, has she left anything, panelists? I think she has exhausted it all, from government leadership to resource sharing data, issues of coordination and collaboration. We can have an addition from, who is ready to provide an addition on that? Dr. Rutasha, can you come in? Thank you.
Thank you, Chief Pole, for that question. And participant to this meeting, perhaps the main question is, what does it take when you talk about synergy and partnership? I mean, what is it really, and what does it contain? The framework of synergies. And thank you very much, Lulu, for your discussion on leadership, which is very important. And of course, she discussed about data and resources. And perhaps I just talk about these two. On data, one time in 2015, I was involved in a major operation. There were more than 20,000 Burundian refugee and asylum seekers. And they came to the crest of Lake Tanganyika, to a place called Kagunga. And they were to be evacuated by MV Liemba, for those who have been in Kigoma. But the capacity of that vessel is very low, so it was taking few of them every time. By then I was working for United Nations Population Fund. So one of my responsibilities was to pick out all pregnant women in that community and ensuring that they are, all those expectant mother, all those who were delivering. So during the second week, cholera erupted. And the people were just admitted on the ground. The people were dying, people were living, the kids, you see. It was catastrophe. It was catastrophe. What I want to drive here is, where do you get data in emergencies, especially when you are talking about the beneficiaries, the beneficiaries who suffer most, because really you cannot talk of catastrophe and emergencies without looking at gender equality. Mostly it is women and the children who suffer most in most of emergencies. So really data really needed to be looking at both and ensuring that you have a very well data which can pull out different kinds of people in the group. The second which I want to talk is about resources. How much is required? It is very challenging. I think we cannot accept, and there's a lot of duplication of efforts during emergencies, and unless people are very well coordinated. What are the government initiatives, really, from our experience? I've been privileged for almost 1 year developing the non-state actors group for health, which I think, in my view, all people are in this group, with the exception of government and the multilateral, the UN, and the others. We are all coming from the non-state actors group for health. And one of the challenge is, how can the government track resources? Apart from emergencies, even in normal, I mean, the government ability to track and mobilize resources for emergencies and other programs. So the challenges are both from non-state actors and from the government. While actually at the national level, you will see that the government is really planning, like the way we are seated here. When you go down at the regional, district level, you don't find those structures functioning. So we have a challenge again on structures, financial systems, which can really track resources for the government and for the implementing partners, which sometimes really end up into duplication of efforts. Those are some of challenges. But Chipo, perhaps there are some other places to talk about, because really partnership is driven from the global level, from the country agreement, signatories of different memorandum of understanding, especially the Busan, the Istanbul, and the previous Paris Declaration, Accra Declaration. And Tanzania came up with a development cooperation framework, which now other levels now align, specifically for the health sector, the common management arrangement. So there are in place system and structures, mainly at national level, but very weak and then almost non-functioning sometime at the sub-national level. Thank you, Chipo. Perhaps we shall talk.
Thank you very much, Dr. Rutasha, for your insights on the dynamics and on the dynamics of partnerships and synergies. Now, colleagues, maybe we may be asking ourselves, what are the opportunities for building or on building, what have been the opportunities on building strong partnerships and synergies from all the previous and ongoing experiences on the public health emergencies that we have been having? Dr. Mbuji, would you like to say something about this? We've been in a series of public health emergencies. We had in the presentation in the morning from leptospirosis to cholera, COVID, dengue, and now measles, polio, and then we had Marburg that has left us with a lot of experiences. So what have been the opportunities for building partnership or putting into practice the partnerships and synergies that we are speaking of here? And were they able to, take us close to the impactful changes that we are speaking about today in this symposium? Karibu sana, Dr. Mbuji.
Yeah, thank you. Good afternoon. Yeah, first I would like to start with when we talk of partnership, definitely there are stages. And some of them do start, but they can also be used alone, the period of, let's say, intervention. The first one, I think Professor Kakoko talked about it, is the issue of communication. You need to communicate if you want to start any kind of partnership, any kind of relationship. Usually that has to start. But then you need to go to a next stage where you need to cooperate. You have to now show some initiative to work together. And that is also very important, very key. But at a higher level, you need to share resources. That is purely collaboration. Now, looking at the issues related to emergencies, definitely you do see that there are some conducive environments that need to start before even the emergencies itself. And some of these include like policies that are in place, legal framework, and also some kind of organizations that can bring people together. But the bottleneck is you have to have a common goal. And the common goal is actually to keep the individuals, communities, and population at large safer and also mitigate socioeconomic impacts. That's very important and is all along different levels, different societies. So looking at the emergencies, definitely you'll start on before, during, and after the emergency. Before the emergencies, for technical people, we all understand that you have to get prepared. You have to get prepared. The opportunity here is that people will sit down, work out on plans, plans to address the emergency. That will be, it's really very important. Looking at, for instance, for Ministry of Health, we do have the strategic plan. For instance, the current one now, Strategic Plan 5, which has stipulated some kind of intersectoral collaboration, the partnership framework, but also there is the relationship of the coordination with the international organization, countries, and the like. So these really bring together the whole idea of people looking at how should we work as partners. For instance, in terms of health and the non-health areas, the issue of like the international health regulations guide us at a local level, but even international level. There are a lot of this. In terms of the, for instance, veterinaries, we have like the performance veterinary service, which is under OIE. All these kind of frameworks bring people together so that they could address the kind of diseases before, during, and even after the outbreak. Now, giving an example for Tanzania, I'll cite an examples in 4 kind of outbreaks that has happened. The first one, the most recent one, I start with the cholera of 2015 to 2018. There, what happened? People did form a certain of coordinating forum, like a national task force. This brought people together. That was an opportunity where different stakeholders and partners could see. They had now to think of different disciplines in terms of the technical areas. Where is the surveillance people, for instance? Where is the laboratory? Where is the SBCiE? And so on and so forth. So those are the kind of opportunities. Now, looking at COVID, or Marburg, which was the most recent because the time is not enough. The COVID, particularly in Kagera, those who have probably had a chance to be part and parcel of the response, you'll find that the first suspect was brought out from the community level. This was the community health workers. These are the ones who actually given abroad to the system that there are several people who have been dying in the locality. And then it was pushed up. But within that, you could see that there are even border guys. This border, they are the one who actually took the patients to the hospital. So you could see that in that situation, there's a level whereby this kind of partnership can go even at the level of the community. But we also have areas like cross-border areas. Cross-border areas, there is opportunity there, for instance, of having like cross-border meetings, even with the neighboring countries, discussing about the risk between the 2 countries and looking at how they could address it. But also within the border itself, you find in that particular like a border post, there are a number of people who are working there. It's not only health people. You find there are immigration, there are people of customs, there are police, and so on. Even at the airport side, we have different people. So this kind of situation, they are being addressed by different stakeholders, different partners to address the situation. There are a number of examples I could mention, but I think the most important one is that of forming technical groups. And these technical groups brings people from different corners depending on the comparative advantage, the expertise. Even, for instance, you could consider like subject matter experts within the country or even outside of the country. So in a nutshell, I know there's a lot to talk about it, but I think these are some of the opportunities that people could see at it in terms of building the partnership and synergies. Thank you.
Thank you very much, Dr. Mbuji. Indeed, there's a lot to talk about. Dr. Mbuji is a guru on emerging and re-emerging diseases, which happens to be an area of focus for SBCiE in emergencies. So we'll come back to you later for recommendations in terms of what will work well for the future. Let's go to Juliet, sitting right next to Dr. Mbuji. What do you think are the challenges in towards forging partnerships and synergies between all these key players, the government, the national level, but different structures at the subnational level, down to the community level? What is your experiences on challenges towards forging synergies? Karibu, Juliet.
Asante. Thank you so much. Good afternoon, everyone. Yeah, I'm happy to be here. I thought I wouldn't make it.
So before I come to the challenges, maybe I can add from what Dr. Mbuji have said concerning the opportunities. During different outbreaks that we have encountered in Tanzania, one opportunity that we have seen in terms of partnership is capacity sharing. Responding to COVID-19, responding to Marburg outbreak, different partners come with different expertise and different knowledge. So during the COVID-19, number of us, we are not aware of what is going on, but there are other partners that at least have the knowledge regarding the disease. So coming together and working together toward that outbreak, we are able to share experience and taking also example of RCCE pillar, you can agree with me, it came to its strength during the COVID-19 response. That's where partners come together and discuss the whereabouts of how to work together in that pillar. And also the outbreak of Marburg, the experience that we had in preparation for preparedness of EVD outbreak, we were able to contain the disease of Marburg because they are interrelated. So I wanted also to add on that. So coming to challenges in partnership, there are many. I'll mention a few and then colleagues may add. We have seen and we are also observing the challenge of coordination. Coordinating partners is a challenge, and coordination we are observing is coming from we can say coordinating the RCCE pillar, but also coordinating partners, and that challenge is leading to partners to work in silos. So at the national level to the community level, each partner is operating in silos because of that lack of coordination. And also coming to the implementation of the response plan. In the outbreak, we have the response plan activities in place, but if we are not coordinated, it means we can delay the implementation of the activities in the response plan, and we can even not implement certain activities which were major to support the communities. Another challenge that we have also observed is the limited capacity to manage rumors and misinformation, especially during COVID-19 outbreak and also COVID-19 vaccine when we started the implementation. But we are happy WHO and UNICEF last year and this year we are able to do the capacity building for how to manage the rumors and misinformation. Now we are coming to the subnational level to do the capacity strengthening. And also priorities, it was also the major challenge, because during the outbreak, any outbreak, it means in the work plan of partners, that one was not in the work plan, the emergency. So when we come together, each partner has his or our own priorities of activities to implement. So that led to delay of implementation and also scarcity of resources. Thank you. Others can add. Thank you very much, Jaliet. Lack of effective coordination, that is a key takeaway from her insights. Partners working in silos. We have colleagues from the subnational level here, from the RHMT and CHMT, but because of time factor, we'll have an opportunity to interact with them in the Let's Connect with Expert sessions to maximize a discussion on that. Thank you very much, Jaliet. Colleagues in the House, you will agree with me that another opportunity towards effective partnerships and synergy is having research and all the research and evidence practices that are being generated from our colleagues from the academic institutions. So we have on the panel Dr. Stephen Kibusi. Can you please come in on that? Tell us something in terms of the opportunity on this partnership with academic institutions when it comes to forging synergies for impactful SBC interventions in the country. Karibu Daktari.
Yeah, thank you very much. I'm also thankful to be here. With regard to the universities, I think the opportunities, they emerge from the challenges that we usually face as a community when the emergency hit. We all know what happens when an emergency happens. I think there is a state of chaos. If you remember the COVID-19, there was a state of chaos. And with a state of chaos, having different partners and everybody trying to respond on their own, you risk duplication. And with the duplication, that means a lot of resources will be wasted, time will be wasted, and so more casualties, and that means poor response to the emergency at hand. And we can speak of preparedness, well and good, but when the emergency comes in, we go back to being human beings. Everybody running scared and trying to save what they can. So I think that is where I see the role of universities as custodians of knowledge and areas where ideas can be cherished and tested. So through simulation and research, I think universities have a major role in terms of research, because if you have ideas and you have researchers, of course, we commit resources, we can at least model these situations before they happen and try to come up with different approaches on how we can effectively respond to an emergency. So somehow I think the university can guide we as a community in a state of an emergency, that somehow we can respond within a researched and a contextualized model for responding to emergencies. And with a well-researched model, that means we want to suffer the effect of the emergency at the beginning, because how we responded to a more chaos and lack of organization in the response. So otherwise, in terms of opportunities, I think I've just highlighted the main functions of a university, because main function is teaching. So that means we needed to integrate lessons learned from previous emergencies, appropriate knowledge that had been accumulated into our curricula, and so empower every aspect of what we teach. I mean, the student that we teach to have a certain level of knowledge regarding preparedness and response. There are issues regarding consultancy. We have expertise as universities, so that means we can offer consultancies and community services at a different level to ensure that our response as a nation or the policy around they have the necessary expertise from the universities, and the help from the expertise from the universities. Another thing, I think, in terms of research, as I said earlier, universities are areas for experimentation, and so researches, ideas, or prototypes for better or technologies for responding to emergencies can be tested, and the universities, so they bring something to the partnership in terms of respond to, yeah. Otherwise, generally, I think as a country, we already have at least the structure on how we respond to emergencies through the Prime Minister's office, and it is decentralized to the lower levels. But I think the need for a well-researched model for partnership itself, and how we address all the components of emergency response, from prevention, mitigation, preparedness, response, and recovery in general, I also needed to be put into appropriate context within the country. Thank you very much.
Thank you very much, Dr. Kibusi. Because of time, let me call in on Kaka Peter Mabwe to give us examples of successful partnerships that have sort of contributed to the depth and replicability of SBCiE intervention in the country. MOH through HPS being a co-lead in terms of coordinating SBCiE and RCC interventions in the country. Karibu sana Kaka Peter. What are the successful examples from previous emergencies?
Okay, thank you very much, Madam Chipole, for this opportunity. Good afternoon, colleague. Yeah, most of my colleagues here have spoken already on the issue of partnership, maybe to build on what my colleague have just pointed out. Partnership was very important. Something which I can start with is that, and which I have learned through responding to these various public health emergencies. Partnership is very central or very crucial or critical to the preparedness and particularly response. So, taking the example of previous emergencies, maybe one of the importance of partnership which I learned is my colleague has spoken about partnership in terms of resources. You know, people say resources are always scarce. So resources, and I can start with the human resources. Partners have been, able to contribute to their human resources. You know, we have experts, a lot of experts from developing partners and implementing partners. So during emergencies, those are also available to team up with the government and the other stakeholders for preparedness and response. We saw this during the COVID-19. And I remember when we started the response, we had a camp at Nimri. Those who were there can remember. So we were like government experts, but also we have, we had our colleague from partners. So taking all the risk to respond, and various from UNICEF, I remember WHO, but also from, by then, Tulonge Afya, USAID supported project and the like. So I think this was, to me, was a good, one of the good example, because then with the pressure of response, you know, sometimes the government official alone cannot perform their duties appropriately and timely, because we have pressure on time, and also so many pressure from community, but also from leaders. So that one I can cite, but also resources in terms of funds. When, for example, the COVID-19 started, it had no funds. So I remember we had some funds for Ebola virus disease. You remember there was a threat of Ebola from DRC. So we had some sort of resources for Ebola, but then due to flexibility of partners, they allowed their such resources to be used for COVID-19, you see. And this went also even to other partners in regions, because given the nature of the COVID-19, it was a new pandemic, so definitely none had COVID-19 in their plan. So there was a flexibility of using other funds, our funds for other programs to respond to the COVID-19. And they also, so this one also helped us a lot in achieving the goal by then. But also, this goes in, together with the leveraging of resources. So it was also from partnership and other stakeholders that it was possible to use resources from other programs to respond to COVID-19. But later on, it also turned vice versa, using COVID-19 resources to address other important issues as well, as we saw that during we used the COVID-19 funds to build the classes and other infrastructure in that spirit. Another one, maybe another successful story for the partnership, Dr. Mbuji has cited about his partnership at community level, so I think this was also very critical. We have several CHW, community health workers, countrywide, who were already trained on various programs, and they were there, so it was easy just to mobilize them and give them some sort of orientation, and then they can deliver. So there was also partnership in the community in terms of community health workers, but also the community themselves. I remember during the COVID-19 vaccine campaign, using the event-based model, then it is very difficult sometimes if the community is reluctant. But then it was okay, because it was like a partnership between the community themselves and the government and the IPs. So it was smooth, and that also helped us to reach to vaccinate so many people within a very short period of time.
People who are being forgotten, but they face a lot of challenges during the emergencies. And always, disability is an outcome. So anyone can get a disability at any point of time. And it's important that we think during these responses to see how persons with disabilities are being considered. I'll give you an example. I'm a sign language user. I'm a deaf. And sign language is my language, my mother language. So every day, I do depend on looking at sign language or using sign language. But there are other groups of disability, the physical, the blind, and other kind of disability. So when we are discussing about emergencies, we are thinking of women's, children's, but we forget a lot about persons with the disabilities. And those people who get a lot of challenges during that situations. And there are kind of disabilities who are very invisible, like the deafness. When you are walking there, no one can really understand that you are a person with a disability. There are a lot of information coming out, but they are not accessible to persons with the disabilities. But there are a lot of stigmas in helping people during the emergencies. People do stigmatize persons with the disabilities. You talked about the issue of data corrections. In most cases, there are those general data that are not disaggregated to understand really how many persons with disabilities were affected by the disasters. And our institutions, we have worked a lot in the policy level, and the United Republic of Tanzania has signed the UN CRPD, which expresses how persons with disabilities should be catered for during emergencies situation. And it gives actually responsibilities to the country, responsibilities to the stakeholders to make sure that persons with disabilities are being part of the plans. So we need to think more about that.
Asante, asante, asante.
Thank you very much.
Asante, we have noted that. Lillian will give a response on that. Can we take all the questions and respond to all of them at once for time, for the sake of time? Karibu.
Thank you very much. My name is Dr. Jeffrey Achai. I think I'll introduce better when I speak on the third day. But as the panel was talking, I did take a few notes and some reflections on challenges and experiences, partnerships. The first one is, from my experience, I would say that coordination and partnership also needs SBCiE. It's a social and behavior change. It's very difficult. You heard people don't actually like to coordinate. They don't want to partnership. So I think that could be the first point of SBCiE. Let them change their behavior. Number two is the magnitude of resources. You have seen from this morning and this afternoon that SBCiE definitely needs resources, and it's sometimes much.
The sentiments of the partnership. The partnership, everybody is saying, is very important, and as everybody is saying, we need to partner with the communities. But partnership with the community.
Yes.
Thank you very much. My name is Ndeniria Swai from RI Good Sharing. Dar es Salaam also we can say something about partners. Partners are important to us because they keep the health care system up to date with the latest health development and the contribution to the service that is within the public interest. In Dar es Salaam, we can say that blood brothers and sisters. We take them as blood sisters and blood brothers. The way we work together, we value partners. We value stakeholders a lot. Dar es Salaam couldn't be here if not the support of partners. And Dar es Salaam is big, we know, everyone knows. It has 102 wards and 564 streets. We have been working with the stakeholders from those one who are in the high level to the lower level, meaning that from the stakeholders who are there, like them, and the community one. In the community, we have the community leaders, tuna wale wenye viti wa serikali za mitaa. We have CHW, we have the trained one, CHW 620, who are not yet enough for us, but those are trained one, though we have more than the society to the global. So if we talk about Tanzania, what we faced in Tanzania, also other countries faced it. Now, can they advise us maybe to have the think tank in health system, maybe in Tanzania, but global, who can talk and support the ministries of health wherever they are and come out with the solution rather than leaving the politician to jump in while they have.
Salam. That was the last insight and question. The first one was an acknowledgement for partners' work in Dar es Salaam. And I think your last question, let's reserve it for the Let's Connect session. And you mentioned that you're here with wenye viti wa serikali za mitaa, ward executive officer from Kinondoni, and mtaa executive officers. We'll give them an opportunity to speak on the later Let's Connect sessions towards the end of the day, just before wrap up. Jalia, can you please? Yes, thank you very much. The HMTs are also here. We acknowledge that. Jalia, can you take her question on that, if partners can plan ahead for emergency support, either Jalia or Lulu? And the other question will be for Lillian from the Ministry of Community Development, Gender, Women and Special Groups. That was about social inclusion for people living with disabilities, from our colleague from Chavita. Karibu sana. Karibu Lillian.
Asante. Nitaongea Kiswahili kwa sababu napenda kuongea Kiswahili.
Karibu.
Asante. Naomba nikujibu mdau kutoka Chavita. Wakati wa majanga huwa tunazingatia makundi yote, na tumeendelea kuboresha huduma kama wizara. Mfano wakati wa Mabag katika timu ya utoaji huduma wa afya akili na msaada wa kisaikolojia tulikuwa na mtu wa kutafsiri lugha. Lakini wizara haijaishia hapo, tumeweza kuandaa mwongozo wa gender inclusion ambao unaongelea makundi yote, na inaelekeza kwamba makundi yote ambayo katika jamii, wakiwepo watu wenye ulemavu, wazee, watoto na makundi mengine, kufikia huduma na taarifa kwa wakati. Lakini vile vile tuna chuo chetu cha ustawi wa jamii cha Dar es Salaam kwa sasa kimeanzisha kitengo ambacho kitakuwa kina ratibu pamoja na kutoa mafunzo ya huduma kwa watu wenye mahitaji maalum, wakiwepo watu wenye ulemavu. Kwa kufanya hivyo tutapata, kwa sababu pia katika utekelezaji tulikuwa tunaona kwamba tuna changamoto katika watu wa kutafsiri lugha. Kwa hiyo elimu kama hizo itaanza kutolewa chuo cha ustawi wa jamii. Kwa hiyo tutakuwa na wataalamu wengi. Kwa hiyo katika timu za utoaji huduma katika majanga kutakuwa kuna watu hao watakuwa wanatoa huduma. Asante.
Asante sana Dada Lulu. I think we need to translate for Professor Wafa and the like. Lillian is saying that the Ministry of Community Development, Gender, Women and Special Groups have already issued a guideline on issues of social inclusion, especially for people living with disabilities. She's also she has also bolded that there is also a specific unit for special needs services that has been established in the ministry, and we believe this will trickle down to the regions and LGAs, so that these services are provided readily for people living with disabilities in all public health emergencies and natural disasters. Thank you. Now to Jaliat for the planning ahead issues for emergency support to the implementing partners in regions and LGAs.
Yeah, thank you.
Do you plan ahead, our partners, or we usually surprise you with concepts? And
I agree with Dada Swai. I know how they are struggling, and they are truly coming to us asking for support during the emergency. But we normally, as we know, during the outbreak, we have the preparedness plan and the response plan. So we encourage preparing ahead of time. In the national level and subnational level, we encourage the development of the response plan with the budget. So normally when we go to the regions or even the national level and they are responding or they are receiving the request, it's only the response plan, the structure. It comes like the narration only, but there's no budget. So we encourage the national plan to go with the response plan to go with the budget. And it's supposed to, resource mobilization is supposed to be done in the preparedness phase. So you look at the human resource and the financial resource. When it comes to the outbreak, it means you have a financial resource ahead of time. So there are outbreaks that we did not expect, but for now, we really needed to have the financial resources at the national and the subnational level. That's what we are encouraging. So when you come to partner, it means we are just working together, but something is already in place. So you know who has what. So I know where that's where it's coming from.
Thank you very much. We will continue with this discussion in the Let's Connect again, because there are so many examples that people send the contingency plans that are not costed. So you later have to call them like, hey, send your budget. So we'll discuss that on the Let's Connect session a bit later. So I'll call in Dr. Ipuge to sort of wind up, give us your insights on the opportunities, challenges, and what are the recommendations for the future of partnerships and synergies based on your experience. Karibu, Dr. Ipuge.
Asante sana, thank you very much. I think, as Dr. Kakoko said, it's not repetition. I would like to underline, because I think, as Dr. Lulu said in the beginning, the 4 components: strong leadership, coordination, multi-sector involvement, resources. Mbuji talked about the technical group, but what I would like to underline is what I learned from working with the networks of people living with the HIV/AIDS. They taught me one thing. They told us, nothing for us without us. And this is what the message I would like to take about the communities. Because this country, we are a big country, more than 62 million people, both parts of the union. But when emergencies come, all of them are potential. So how do you plan with all of those? The only thing you can do is working with the community, and the community systems have proven to be the answer. And I think Professor Munodawafa talked about the earlier emergencies. When you look at the Ebola emergencies of 2014, countries or communities with existing networks of community health workers are the ones which are embedded within the communities, are the ones which managed to address the Ebola epidemic faster than the rest. So it means we have no option. We have to underline the importance of community health workers in public health emergencies, including and in particular for social and behavior communication, because they're the ones who are community level educators. They are the ones who can help to address the misinformation and whatever at the community level, because when you go to the WhatsApp group, social media group, there's a lot of misinformation. So using what our friend talked about, artificial intelligence and whatever, if we can channel to them correct information to demyth the myths which are being produced, it will help a lot, both from surveillance, so that we are aware of the emergencies before they come, during, and even after. So I would like us to underline, when we are talking of partnerships, we should, of all those components, look at starting at the community, and I think as RHMT mentioned, actually we should plan from bottom up, so that we don't plan for them always, but we have to empower them to be like that. So I didn't want to repeat, I just wanted to underline that. Thank you.
Thank you very much, Dr. Ipuge, for underscoring the role of community engagement if we really want high impact SBC interventions. So
Sorry, can I come in one thing I forgot?
Karibu.
In the last 15 years, I think we have done some mistakes, you see, with the community. We had, I know the village health worker program, which worked very well, was good, but then we had programmatic. Then the government tried to come with a very good program where the community health workers were, a cadre was created. And then 5 years took to plan for that. When it started to be implemented, it was dismantled. We went to the volunteer, it has been planned. So now we have a new program. So I think we should stop tinkering and planning. And this new program which they have, the government has led, which by the end of 2028, we should have about 137 community health workers, male and female, in each village, in each mtaa. And this is a beautiful plan. I think we should all support it and make sure it works. And that will help us for all health programs, but in particular for emergencies and whatever. Asante.
Thank you very much. Again, the role of community health workers in ensuring that we have SBC and public health, impactful public health interventions in general. Thank you very much, Dr. Ipuge, for winding up with that. I know that we are not doing very well. We are doing very bad with time, but the discussion was very interesting and fruitful. I urge you to, reserve your questions in a parking lot, and we will have an interaction later, like I said, with these panelists and all the other experts in the room. I would like to thank you very much, my panelists. Thank you very much for your insights, experiences, and contributions. Thank you very much. We'll catch up later with you. We are not done yet with you. Thank you very much. Thank you very much, members of the House. Can we have you all stand up for a group picture?
So let's also give a big round of applause to Dr. Chi. Round of applause to Dr. Chi. Naomba tumpigie makofi mengi Dr. Chi. Kwa kazi nzuri ya kumoderate session ngumu kabisa. I think when you're moderating a pool of experts, it's never an easy task. So thank you very much. I'm about to bring, so please, you may take your seats now. Camera, mmeshapiga picha? Hold on, okay? We can at least smile. We can't be speaking partnership and then have long faces. Yes, closer to that. Okay. Asante sana. Thank you very much. So as I'm about to bring Priscilla, it caught me wondering why the sustainable goal, the very last sustainable goal, which is number 17, speaks about partnership. If I were to decide which goal should have been number 1, it should have been about partnerships, because anything whatsoever, even when you want to have your own me time, you have to be in partnership with the people who would make noise and you miss your me time. Okay? So I came to find peace with myself, because even David in his family was the last born, but was now the turning point for the Israelites. So I totally agree that partnership remains vital. Now I'm bringing to the stage 2 more people. One is Dr. Priscilla, to sort of like wrap up this session. She was supposed to give us a curtain raiser, but because of technology, it couldn't work. So she's coming up to briefly speak about the session, and then I will invite Professor Kakoko to close the day. Now we're closing the day in terms of speeches and this and presentation and all that, but we are going to a very interesting session which I will speak about right after or just before he comes to close the session. So for now, Dr. Priscilla Karibu. A round of applause to her as she comes to the stage. Can I wake everyone up? Can we please wake up? Some of us are not with us mentally and they are with us physically. Can you all please stand up and do a bit of a stretch, kindly? Let's stretch up.
Yeah. Yes, I'm not going to take much of your time. Good afternoon once again, colleagues. I'm not going to take much of your time, but I think I'm just going to tease out the key issues which I would like to complement from what the speakers have said. But what we'll do is we'll share this presentation in case you want to go through everything. I think the first issue that I want to really plug in from the moderated panel discussion that we have had is that we managed to really extensively talk about the partnerships, but there is also a synergistic component that we have learned here in Tanzania that if we manage to unpack it and optimize its usage, we realize a lot more than when we just focus on partnerships only. In terms of partnerships, like I said, for the social and behavior change in emergencies here in Tanzania, we have about 35 implementing partners, but when you look at the synergies among those partners, probably it's 5, 6 implementing partners closely working together to produce a combined effect. For the synergies, what we have learned also is that synergies can also exist in different partnerships. And one of the things we have also learned is that when partners synergize efforts, I'll try to unpack the synergies part of it. When partners synergize efforts, issues around replicability and scalability are actually easier to deal with, especially in the context of emergencies. This is mapping, okay. This one. All right. So in terms of how we have also approached it as UNICEF, we do have quite a number of partners that we have engaged, but one of the key issues also that I want to focus on is the need to really categorize the partners in terms of exactly where they are, what are they doing, with whom, so that we can identify the gaps. If you look at these partnerships that we have as UNICEF, it's different specific technical areas which are high impact when it comes to social and behavior change in emergencies. Another aspect really that I want us to look at, which we found very interesting also as we were implementing partnerships and synergies, is around mapping the different areas where we would like to synergize efforts on. The first aspect is on the platforms themselves. Those are key areas where synergies can actually be done. And then another area to look also on the typical synergy values. What we have found very interesting around the values is something to do with tackling complexity. I think you have seen the input from our colleagues from Chavita and also the private contributions. But there is one last slide that I want us to look at, this one around synergy mapping, where we need also to understand as we develop synergies where we are. What are the linkages between the partners themselves? Are they weak? Are they strong in terms of strategic alignment of the partners?
So this has been our experience here. We also need to understand the partners that are synergizing efforts, what are the status of program implementation activities. I'm saying this with the understanding around the challenges that we realize as we continue to do partnerships, as we continue to do synergies, issues around conflict, issues around risk sharing and risk mitigation. Those are some of the things that we have continued to learn when it comes to doing partnerships and synergies, especially during emergencies where issues around life-saving, quick interventions, and also social accountability are involved. So I think that's about it, colleagues. But as I conclude, you can ponder on this. We have tried to map all the partners that we have. Why partnerships and synergies? What do we need for us to scale and replicate, especially around documentation, resources, and among the many other things that colleagues spoke about. So this was just a marathon. Sincere apologies, but I hope you managed to pick one or two issues. Thank you, colleagues. Asante sana. Was I good on time?
Dr. Priscilla, I picked a word younger on your slides. Is it the younger that I know? Yeah, the younger that I know. Thank you so much. Okay. A round of applause to Dr. Priscilla. Thank you so much. So, as soon as Professor Kakoko is going to wrap up the day, we are going on to two sessions whereby we are bringing now the experts to you. They're seated and they're mingling with us. We probably do not know them. I will call them and ask them to kindly stand up. They will be in two separate rooms. This is called Kilimanjaro, so I will mention those who will be in Kilimanjaro, Meru and Kilimanjaro, and the other experts will be at Udzungwa on the first floor. Now, the essence of the next session, which is Let's Connect with Experts, is actually to give you a room to do one-on-one with them. Okay? So I'm hoping that this is not very common to actually have an expert waiting for you to connect with them. So let's make the very best of this time now. And after that, we will then be very good to go. So for the experts who will be in this room, and for those of us who would want to meet with the following experts, kindly take a note. May I request Professor Wafa to please stand up? This is Professor Wafa. Thank you so much. Okay, so Professor Wafa will be in this room. Professor Kakoko, just wave from your distance. Please be seated. Thank you so much. Will also be in this room. Dr. Felix is not here. Elisha, please stand up. So Elisha will also be in here. If you AI, thank you, Elisha. Dr. Rutasha Dadi, kindly stand up. There's Dr. Rutasha. So for those of us who would want to connect with Dr. Rutasha, he will be in this room. Professor Nyamuhanga, Prof, I'm not sure if Prof is in. Prof is not in, okay. Professor Collins, please just rise up. This is Professor Collins. He's going to be in this room as well. And our dear Awet, there she is, UNICEF. So please, if you want to mingle one-on-one with these professors and doctors, aspiring doctors, and Awet, I believe you're an aspiring doctor. One with the ones that just stood up. Please stand up. Gasto. Frumenx. Gasto's just stepped out. He's probably headed to Udzungwa already. Dr. Shepherd Mudavahu stepped out as well. They're probably ahead of my time. Dr. Priscilla, please stand up again. She's just finished her presentation. So just in case you want to follow up on a presentation, do one-on-one with her. She's going to be at Udzungwa. Dr. Yahya Ipuge. Thank you so much. Daktari, if you want to follow up with Dr. Yahya Ipuge, then it's going to be at Udzungwa. Professor Egidius Kamanyi. Yes, the man of the house. He will be at Udzungwa if you want to connect with him. That's Professor Egidius Kamanyi. Dr. Godfrey Akaye. Dr. Godfrey. Thank you so much. Just wave. You can see him. Is also going to be at Udzungwa. Dr. Gemini Mtei. Dr. Mtei. She's not here. I believe it's a lady, yeah? No, it's a man. I'm sorry. Dr. Gemini Mtei is not here. Dr. Peter Mbuji. Thank you so much, Dr. Peter. We all heard his insight as well. Is going to be at Udzungwa. So just for quick highlights, as soon as Professor Kakoko is going to give us a closing remark for the day, we shall proceed then into the respective rooms. Those of us meeting those experts in here, we stay back, and those going to Udzungwa will go to the first floor. I wish to also remind us, as I will not be speaking again on this platform, that we are resuming after the meet and greet and exchanging. We shall then be allowed to go home and or take personal schedules, and then we meet again tomorrow at exactly 8:30. If you can be here before 8:30, because at 8:30 that is when we're going to start the program. So between 8 and 8:30, tea will be served and we will be good to start. Without further ado, Professor, over to you. Karibu sana.
Yeah, thank you very much. Let us put our hands together for our MC of the day. Yeah, he has done well. I think you are all the witness of what he has been doing since the morning. He has been on his feet, and he has been struggling to make our timetable go as it has been it was planned. I should thank you all for having attended this the first day, and I'm sure we have learned a lot on this first day of the symposium, where we had different presentations that started early in the morning. Though we dread a bit to start the program, but at least the MC strived a lot to make sure that we catch up with the timetable. From the opening remarks by the Vice Chancellor of Muhimbili University of Health and the RD Sciences, who assured of the cooperation with the Muhimbili University, which has been established between MUAS and the UNICEF. We are also fortunate to have greetings from different key partners, the WHO, USAID, CDC, who gave us at least a bit of the talk from their perspective, from their positions, and we realized that they send the right persons who are responsible with the social and behavior change communication. To me, that's a success, because sending the right persons, it means a lot in terms of forging the synergies with those key partners in this country. So we thank them all for having attended and for their words. Now, we had the opening remarks, keynote speech by Priscilla, who took us through key issues of this symposium, including the objectives. And she highlighted, she gave us at least the roadmap of the 3-day symposium. So We are going to, for the 3 days, we'll be following at least that presentation, what she highlighted as the objectives and the outcomes of this symposium. We also thank the speakers. We had a number of speakers, mainly 4 speakers. The first speaker, who was Professor Munodawafa, Professor Munodawafa, who talked about the lessons from the past public health emergencies and diseases outbreak, challenges and the opportunities. That was an icebreaker, telling us about where we came from and the historical mirror of what we have been going through, but importantly highlight the challenges and the prevailing opportunities. But I also talked about behavioral sciences and its application in context of social cultural anthropology, and also in context of social and behavior change in emergencies. And that talk highlighted key issues pertaining to social and the behavior change, as well as the principles of behavioral sciences. We also had the third speaker on the role of information systems and the artificial intelligence. That was Erisha, who made a good presentation telling us about the aspect of artificial intelligence that we are all the witness that this, given the technology, as the MC said, you can run out from different things. There are the things you cannot run from. If you run from technology, you're welcoming poverty in your life. I see some people saying that because of my age, you see issues of technology, to me, I can't. If you dare to do so, then really, where you are heading into problems. Make sure that mingle with the young people, try a lot with the technology. It might take time for me to go into issues of artificial understanding, clear artificial intelligence, but I'll be striving, make sure that that's a must, it's not the personal will. And we need it throughout our life, the coming life. So thank you for that presentation. Again, that was on aspect of social behavior change, social and behavior change, but later on, we embarked from the 4th presentation, we embarked on different aspects, including issues of how do we engage the community. So issues of partnership was also key in the later presentations. Yeah, Priscilla's presentation, of course, was meant to start from the beginning, so as to give the dynamics of the issues of partnerships, but at least in few minutes she had highlighted what we are supposed to understand in terms of engagements and issues of partnership. I'm sure we're going to read her presentation and we are going to benefit a lot, not only in this meeting, but also in the near future as we need this information. But key to this meeting, to this day, was the moderated panel discussion led by Madam Mperembe, who led that discussion. She did it in a much more professional way. Thank you very much for having organized it the way you did it. But you had different speakers that we saw: Ruru Jariath, Dr. Peter Mbuji, Peter Mabwe, Dr. Rutasha, Dr. Yahaya, Lilian Masua, and Dr. Kibusi. All of these people are the experts we are going to meet shortly. As the MC said, you are going to meet them shortly, and I'm sure we may have a lot of things to ask. They hold different expertise, they have different positions, but they also made the highlight of the key issues when it comes to partnership. And really there are very few questions, but more of the comments that I think we can continue at the part of the last session where we connect with the experts. So we're going to connect with those experts at the MC told us in the 2 sessions. So in the nutshell, this is what we managed to accomplish on our first day. And I'm sure the first day is always not that easy. There are a lot of things to arrange. There are things to get accustomed when it comes to the context of the workshop. But I'm sure tomorrow, as the MC requested that we come here very early so that we start the meeting, get more time to discuss, we get more time to ask questions. We are all experts. We have expertise in different areas, and given our expertise, we need you all to be here so that we continue interacting for the future of our public health. Having said so, I request that if there are no any other announcements, then we break into the group C as the MC said. Here's a word to tell us, just wait.
Out of curiosity, do people know everyone? Asante sana. Can we put our hands together for Professor Kakoko for that wonderful summary of the day? I am wondering, some of the professors and doctors that are going to be on the session now, we may probably not know so much about them, so can I give them just a minute to tell us briefly about themselves so that we may be able to know and engage with them. Those doctors and professors and who did not have the opportunity to come to the stage today, can you quickly just do a quick round? Are the mics on? Can I start with you? I'm not sure if you were on the stage today. Just tell us what your good name is again and your specialty.
Hello everyone, Collins Ariambua. I'm with Georgia State University in the US. Sorry I came late, flight delay and all that, but I'll be speaking tomorrow and I'll have that opportunity to interact with you. Good to be here.
So again, your good name again is?
Collins Ariambua.
Okay, so this is Professor Collins. He's gonna be in here. Okay, he will be here. If you want to engage, then he's gonna be in here. I'm not sure if I had, Rutasa is not here, right? Rutasa, did you have the opportunity to come to the stage?
Yes.
Okay, fantastic. And we heard from Awet. Those from Udzungwa, Frumens, we did have Frumens. Is already outside. Shepherd, did he speak? Okay, Shepherd, do you mind introducing yourself? Tell us more about you briefly, and so that we can be able to engage with you.
Hi everyone. My name is Dr. Shepard Mdalanu. I'm an economist. I have a PhD in economics. I'm also a health economist. I'm from South Africa, working with the Council for Scientific and Industrial Research as a climate and a health economist within a senior researcher capacity. I'm also an extraordinary senior lecturer at the University of Stellenbosch in Cape Town. I'll be speaking tomorrow just before lunch. So I'm looking forward to engaging with you. Thank you.
Thank you very much. And Dr. Shepherd, and we look so much to your presentation tomorrow, but again today, for those of us who have never engaged with an extraordinary doctor, this is the opportunity. So thank you very much. We've had Ipungwe, we've had Kamanyi is the one who is not present, I understand.
No, I'm here.
Kamanyi?
Yes, I'm here.
Kamanyi, you only had the time to ask questions, but not to present anything, right?
Yeah.
Okay, so can we know your specialty briefly so our audience can engage with you?
Thank you. By the way, I'm not a professor. I'm a doctor, lecturer at the University of Dar es Salaam. I am a medical anthropologist, sociologist, and I do disaster management. And I've, apart from research and teaching, I have conducted a lot of studies as a consultant, one of which I've worked with UNICEF and some of the partners in this room. And I will be presenting the third day in the morning. Thank you.
Thank you very much. He is going to be at Udzungwa down the first floor. Akaye? Right before the microphone. Yes. Awet, can you help us with the mic? It's the button just before the mic. Right under the mic, yeah. Same line with the mic. Yes.
Okay, thank you, MC. My name is Dr. Jeffrey Achaye, not Akaye. Medical doctor, public health, and health manager. I've been working with UNICEF before in several countries, but now I've retired and I'm doing some private work with some NGO for welfare for my community in Uganda. I retired recently, the last 4 months. So what I'm presenting on day 3 is something to do with community-based disease surveillance. This was my topic for my master's thesis, and I will tell you the experiences on it and why I chose that topic, and I think it's quite relevant to SBCiE. I've been closely involved with SBCiE colleagues for all the time I was with UNICEF, which is 20 years plus. So right from the time that it was health promotion, C4D, then RCCE, SBCiE, and now SBCiE, all those stages I've witnessed. And as we talked about partnerships, as a health manager in UNICEF, we were working very closely in partnership with the SBCiE colleagues. So that's really my experience. I'll share with you the experiences on community-based disease surveillance during emergencies. I've just picked on 3 emergencies, and we'll see what was the experience. So thank you very much. It will be on day 3 in the afternoon.
Thank you very much. Achai, did I get that right? I think the only other country that I know that has C for CH is Italy. When they say Ciao, it's actually Ciao, and C for CH. So thank you, Doctor, for that correction. Peter, did we have Peter on the stage at some point in time? Peter Mbui? He did. Yes, you're just on the plenary. So I am very skeptic, but this is my personal view, that those who did not have the opportunity to come on stage and share insights may not necessarily have people to engage with, but please go to your respective rooms. However, I think the organizers will plan accordingly, that on every end of the day we actually have session to engage with you, so that at least by the time we leave, we do not leave any stone unturned. So once again, thank you very much. Let's now go and engage with those experts at here Kilimanjaro and Udzungwa on the first floor, and let's meet before 8:30 tomorrow morning. Have a very wonderful evening. Thank you all. So the experts can go to the respective rooms, find a spot, sit, and it will be upon us to spot them and go engage with them. Thank you.